Good evening. I welcome you all to this monthly meeting of Tamil Nadu ISG. Today we will start off with welcome address. We would like to welcome our President, Dr. Eapan, and I would request him to give an introductory remark as well. Thank you.
Thank you, Pirma. So, I was not sure whether I should say the welcome or I should say introduction. Anyway, so it's what I'm going to talk is neither. It is just from food for thought. So it's not welcome nor introduction, just from food for thought. So sometimes we hear some stories which are sort of extreme, but it sort of stays with you. So let me share a small story which some of you may have heard. So this is this picture which some may have seen, some may not have seen. So this won the Pulitzer Prize in 1994. So this picture was taken by a South African young journalist, photojournalist. So this is from Hindu. So there's a vulture in the picture. It looks as if the vulture is waiting for this child to die. And this is happening in Sudan. So the photographer is evidently coming from some well-to-do area, and where there's no war, and that's his job. So he's captured that event, and that was it was not a staged event; it was a true event. So it's good enough to win the Pulitzer Prize. So some 3 months later, it's a true story. You can Google it, you'll find it out. So when the award function came, later the press met him, and he asked this young chap, "What did you do? What did you do for the child?" So this is a war area, and this is a refugee camp. This child may or may not survive. So even this week I was reading in Hindu paper in the middle center spread area that the journalist's job is not to give out money. The journalist's job is to go and report. And often people ask for money. And they say by bringing out the publicity, people will donate. That's what. I am not going to give money. But somebody asked the Pulitzer Prize winning person, "What did you do?" So this person, I think his name is Kevin Carter, 3 months later committed suicide. Once he couldn't handle it. What did you do? So this is in Sudan, which became South Sudan later. South Sudan now is the poorest country in the world. So the next 3 minutes are on South Sudan. So South Sudan in Africa, that's where it is. And when it became independent, the US government was important player in making it independent. So the American president that time gave the Sudan president, who's on the left, a gift. The gift was a hat, Stetson hat. So he's wearing it. He likes wearing it. He's wearing the Stetson hat. And some of the tribes in Sudan are very tall people. So in fact, many of the people in the NBA basketball in America are from Sudan. So one such player is there. So these are very tall people in some of the tribes. Now, so this is and the picture turns out to be from Sudan many years earlier. Because that's an area where always the normal life is all war, and between tribes, they are sort of fighting each other, etc. Now, at Vellore, many years ago, I was a student. I joined in 1983 as a medical student. So in my batch, 2 of my batchmates, Anil Cherian and Shalini, they got married to each other. So one guy, Anil, is a pediatrician and Shalini is a gynecologist. So after working in India in different parts in North India, etc., Shalini is from Erode and Anil is from Hyderabad, but from Kerala, Hyderabad. So that's their background. About 15 years ago, they moved to South Sudan. It's amazing. So this is a true story. They are my classmates. So they felt we should go and start training doctors in this area. But they decided they will not start MBBS Because the moment you finish MBBS, they will all migrate to UK. So they started something like our LMP program in India. So I can't go to UK. My degree is not valid. So if you have to find your business, you have to do it there only. So when they started, they found that this country was too unsafe. So they went to a nearby country. They went to Uganda, which has got a border of South Sudan, and 50 students they took in. And because in the WhatsApp group, we know from our batch, it's all happening 15 years ago. And when their first batch passed out, 5 years later, the health minister, the country's health minister, South Sudan, said, "You've doubled our medical manpower." That's what they did. And when our class met, they told us, in the final exam, one student couldn't come. The student got kidnapped on the way for the exam. It's a very unsafe place. Now, so they are about to leave. They will, another 2-3 years, they'll come off. They spent about 10-12 years there. And that's the institute they've sort of established. Now they moved into South Sudan. So what do they teach? There's nothing very much there. There's hardly anything there. There's no endoscopy. They can do blood sugar, they can check for malaria, they can check for hemoglobin. And what do they do? So I don't know what they do. But they seem to impact the place. So here is a write-up by one of their students. I'll read it out. That's a student's name, and the picture is there in the student, I think. So that person says, who's passed out, he's saying, I see more than 200 patients a day at a primary health center in South Sudan, mainly refugees with war trauma. Fighting breaks out periodically. Many medical personnel have been killed. What encourages me? Patients brought in unconscious. Later on, I discharge them when they're fully okay. I love my profession to save lives. That is why I am here, where I am, far away from my mother. My mother told me to leave here because of insecurity. I tell her God will protect me and I love my job. So this is my last slide. So I think, as I started to say, this is an extreme example. But surely, this applies to all of us. We are the privileged in our society. I didn't mean TNIG society. I'm saying as a public, as members of public. We are the privileged. We are the well-off. I see this is the role TNIG has been doing. I'm just emphasizing that. We are using the tools from science to bring light into a dark world by education and by research into finding out solutions for what we face, problems that we encounter. And they are all among in our own society as well, community as well. We just have to look out for them and then address them. Thank you. So those are the few thoughts I want to share.
Thank you, sir. Interesting thoughts. I think now we will move to the postgraduate session now. We'll start off. We'll have about 4 cases. And this time around, we will start off with one other new initiative whereby one medical college or medical institution will have an Indian literature review on a topic of what their choice. And I hope after they do a good, thorough literature review, the same should be sent as a manuscript to our own journal. I believe that people from other states, postgraduates from other states, are already inquiring. I don't know how they got the program list, but I think from someone from Maharashtra are already inquiring whether they can get a link for this kind of that specific topic about Indian literature review. So I think if we put it up in a journal for posterity, I think it will be very useful for all our postgraduates even in the future, and that will be of great use. So I hope that part also is taken seriously and it is submitted as a manuscript to our own journal. So I'll request the moderators, chairpersons to take over the stage and conduct the proceedings. And Dr. B. Sumati, Dr. Balamurli, Dr. Muthukumaran, and Dr. T.G. Balachandar. I think some are still on the way. I think Madam can start off and we will take it.
Good evening, everyone. It's indeed a great pleasure to see you all at this evening. I invite the first postgraduate to present the literature review. Case report. Actually, it's a rare case of hemolytic jaundice unraveled from SRMC. Dr. Mr. Dheeraj, please.
Good evening, everyone. Today I'll be presenting an unusual case of hyperbilirubinemia under the guidance of Professor Dr. Ganesh. Coming to the case presentation, a 49-year-old male resident of Kolkata presented to us with the following complaints: yellowish discoloration of eyes for the past 30 days, abdominal pain for the past 30 days, fever since 15 days. The patient presented elsewhere and was treated for 7 days for similar complaints, for the given complaints. Coming to the history of presenting illness, abdominal pain since 30 days, acute onset, which is gradually progressive, dull aching type of pain, lasting throughout the day. It was diffuse, there's no relation to food intake, it was non-radiating, and it relieved on taking analgesics. Patient gave history of decreasing intensity of the pain for the past 5 days. Patient also simultaneously noticed yellowish discoloration of eyes and urine since 30 days, which is insidious in onset and gradually progressive. Also had fever since 15 days, which was high grade and associated with chills. It was not associated with abdominal distension or vomiting. There's no history of clay-colored stools or generalized itching. He did not give history of altered sensorium or any bleeding manifestations as such. There was history of alternative medicine intake for 2 days in the form of oils and tablets. Coming to the past history, patient was incidentally detected to have high bilirubin at the age of 18 when he was admitted for fever at a local hospital, and he persisted to have high elevated bilirubin levels. This was later evaluated at Kolkata at a tertiary care hospital and was told to have a benign liver problem, probable Gilbert syndrome, and was reassured. Patient did not have any other associated comorbidity. Coming to personal history, patient does not consume alcohol nor is a smoker. There's no addictions. Bowel and bladder habits were regular. Surgical history and family history were not significant. Coming to the investigations of the patient which were done at Kolkata. At presentation, the CBC showed a HB of 10.9. Platelets and total counts were normal. INR was normal. Coming to LFT, the bilirubin total was 22.4. Direct fraction was 13.65. SGOT and SGPT were elevated. Serum alkaline phosphatase and GGT were elevated as well. RFT and electrolytes were otherwise normal. LDH was elevated with a fraction of 226. Serum iron, total iron binding capacity were normal. Ferritin was elevated. Total cholesterol, triglycerides were normal. Patient was evaluated for causes of hyperbilirubinemia. Direct and indirect Coombs tests were negative. Reticulocyte count was grossly elevated with a value of 11.6%. Serum ceruloplasmin was tested in this case and was normal. Patient also underwent autoimmune hepatitis panel, which was negative. G6PD assay was done, which was normal. HB electrophoresis was done, which was normal. Virals were tested, including hepatitis B and hepatitis C were normal. In view of patient presenting with fever, patient was tested for septic workup, including malaria, leptospira, dengue, scrub typhus, which were negative. The cultures, blood, urine were negative. Patient was further evaluated with CECT abdomen, which showed a well-circumscribed, minimally enhancing mass lesion in the left para-aortic region with lateral limb of left adrenal, which was not separately visualized from the mass lesion. And there were areas of macroscopic fat density and hemorrhage in the lesion, which is probably reported as likely adrenal myelolipoma. There was associated cholelithiasis. So it has been mentioned that to rule out cholelithiasis, he underwent an MRCP, which showed no evidence of cholelithiasis. In the course of hospital stay in the tertiary care center, patient had received 1 PC transfusion and was discharged with UDCA, oral hematinics, Dufalac, opt-in urine. Patient next presented to SRMC in view of persistent jaundice and persistent high-grade fever. There were no other fever localizing symptoms in the form of shortness of breath, burning micturition, joint pains, or rash. At presentation, on examination, patient was febrile, was tachycardic, there was significant icterus and pallor. Patient also had bilateral lower limb maculopapular rash, which was scaly and was present up to knee. On systemic examination, patient had gross splenomegaly. Coming to differential diagnosis at this point, after patient being extensively evaluated at an outside center, we came to a conclusion of probable infective causes of hepatitis and probable drug-induced liver injury which could have explained hyperbilirubinemia and a sepsis of unknown etiology, which has to be investigated further. So coming to labs at SRMC, At presentation, patient had severe anemia with HB of 3.4. Patient had leukopenia with the counts of 3,530. RFT, serum electrolytes were otherwise normal. LFT showed a total bilirubin of 3.59, direct fraction of 1.30. SGOT, SGPT, alkaline phosphatase, and gamma GT were normal. Reticulocyte count done at our center was normal. LDH done at our center was normal. So in view of anemia, stool occult blood testing was done and was negative. We have reassessed for viral etiologies and were negative. Urine routines were normal. Peripheral smear was done for this patient, which showed low count, markedly reduced hemoglobin density. The RBC appeared normochromic normocytic, associated with rounded RBCs. Polychromasia was not present. WBC count was low. Platelets were adequate. There was no evidence of any hemoparasites. It was a normocytic normochromic anemic picture with probable spirocytosis. This was probable only because it was very occasional rounded RBCs were identified in the peripheral smear. The number was not very grossly significant. We have tested him for Coombs, direct and indirect, which was negative. Serum ceruloplasmin and urinary copper levels were done, which were normal. Also tested for hepatitis A and hepatitis E, which was normal, which was non-reactive. In view of anemia, patient underwent endoscopy, which showed lax LES, and the duodenal biopsy was taken in view of anemia and was turned out to be normal. CT abdomen was done, which showed a well-encapsulated heterogeneous lesion of size 7 into 6.9 into 8 centimeters, which is found in the retroperitoneum, arising from the body of left adrenal gland. On contrast, it showed heterogeneous enhancement. The gallbladder was distended and showed few caliculi, with the largest measuring 15 into 10 mm. The wall appeared thickened. So the CT final impression was adrenal indeterminate lesion, which is a probable adrenomyelolipoma, cholelithiasis, massive splenomegaly, and few enlarged abdominal lymph nodes were identified. So in the course of hospital stay, patient had to undergo 6 packed cell transfusions, secondary to which we have taken a hematologist opinion and have advised for bone marrow biopsy and PNH flow cytometry. Bone marrow biopsy revealed erythroid hyperplasia with megaloblastoid marrow. CD markers for PNH were done and were negative. So at this point, suspecting marrow suppression, patient was tested for any infectious causes of, associated with underlying hemolytic anemia in the background of a normal reticulocyte count. Patient was tested for parvovirus at this point, which has turned out to be positive. It was IgM. The titers were pretty high. So in this case, there was evidence of hemolysis, there was evidence of indirect hyperbilirubinemia, and a suspected spirocytes in the peripheral smear. A parvovirus infection being positive, we came to a conclusion that patient has a probable hemolytic anemia with parvovirus probably causing marrow suppression, which did not reflect as elevated LDH nor elevated retic count. So secondary to this, we have done a clinical exome study which showed pathogenic gene for hereditary spherocytosis, which is ANK1. So our final diagnosis in this case was hereditary spherocytosis, parvovirus infection with aplastic crisis, probably causing the marrow suppression, which is now patient has now recovered from which, and evidence of cholelithiasis. So the diagnosis of Gilbert syndrome, which the patient was previously labeled, does not stand in this case, as it is confirmed that he is having HS. We were looking into causes of indirect hyperbilirubinemia, ma'am.
Fever, abdominal pain, and chills.
It was infectious causes of hepatitis initially, ma'am, and cholelithiasis. Sorry, ma'am.
Something beyond that, do you still consider him obstructive jaundice as a postgraduate? Because fever, abdominal pain, and jaundice with chills.
Yes,
You
ma'am.
like to keep only your intrahepatic causes, in other words, only eptocellular cause, or in other words, obstructive jaundice as well.
Cholangitis.
This way, for the postgraduates, yeah.
We were suspecting cholangitis as well, ma'am. But as we received the patient, the investigations have already been done, so we have grossly ruled out that cause.
Smear report on the first occasion.
Peripheral smear was not done at the center, ma'am.
What do you see on a peripheral smear for an underlying hemolytic disorder in general?
Any evidence of presence of spirocytes
No,
or
what is the cause of hemolytic anemia? Some clue on a peripheral smear make you think the child can, or he or she can have some underlying hemolytic anemia.
Polychromasia, yes, sir. Not there, ma'am, not present.
The hemoglobin is very low and the platelet should be more.
Yes, ma'am.
Platelet is normal.
Platelets are normal, ma'am.
And what about your adenomyolipoma? Do you feel it's just an incidental finding?
We are going with it as an incidental finding, ma'am.
In Gilbert's, usually asymptomatic.
Asymptomatic and
Now your indirect jaundice
yes, ma'am.
and your retic count, everything will be normal.
Yes, ma'am.
On first occasion, I think the gamma GT was very high.
At presentation, the retic count was elevated, ma'am.
Gilbert syndrome, everything will be normal. Sometimes I can have a mild splenomegaly, but not to the extent of 10 centimeter.
Yes, ma'am.
So asymptomatic, except for indirect jaundice, Gilbert is less likely when they present with this clinical presentation. So I think that makes you think Gilbert is unlikely even on first occasion.
Yes, ma'am.
Parvovirus
Yes.
can cause a bone marrow suppression.
Good evening, everyone. I'm sorry, I was a little bit late. I was caught in the traffic. So, yes, some more slides.
So I wanted to discuss about few case reports on parvovirus infection in adults. So there are multiple case reports which are showing that parvovirus is in adults is usually associated with any underlying hemolysis, usually presents with bone marrow suppression, chronic anemia, or aplastic crisis. So there are case reports with which parvovirus usually presents as in anemia, but there are not much case reports wherein parvovirus presents as acute liver failure or hyperbilirubinemia, that to a value of 22. All of the case reports from 1980 till 2010 in the literature showed a maximum bilirubin value of 6. So in our case, we are suspecting it to be a parvovirus causing hepatocellular injury associated with CAM intake and an underlying hemolytic anemia, which could have caused hyperbilirubinemia. So coming to parvovirus, it's a small single-stranded DNA virus. The lack of lipid envelope makes it resistant to physical inactivation with either heat or detergents. The virus targets rapidly growing erythroid progenitor cells, which are found in human bone marrow, fetal liver, umbilical cord, and peripheral blood. These patients usually develop chronic anemia, pure red cell aplasia, less often leukopenia and thrombocytopenia. The usual clinical presentation is erythema infectiosum, fifth disease, which presents commonly in children, arthropathy, transient aplastic crisis, chronic red cell aplasia, glove and sock syndrome, and hydrops fetalis. In our case, patient had bilateral lower limb maculopapillar rash, which was extending up till below knee. So we are suspecting it to be the presentation of glove and sock syndrome.
So is it something like unmasking of your spherocytosis by parvovirus? That's what you meant to say?
Yes, exactly, sir.
Was there any history of transfusion? It was a little bit late. During childhood or something like that?
No, sir. No previous history of transfusion, sir.
But patient was quite all right.
Yes,
Was
sir.
there any hospitalization previously?
No, sir. At
No,
the
that
age
was-
of 18, he was hospitalized, that too for a short duration of fever, sir. That was when he was diagnosed to have high bilirubin, and he was labeled as Gilbert syndrome, sir.
So how do you diagnose Gilbert syndrome? You have some problem here because they thought of Gilbert syndrome, you have diagnosed something else.
Yes, sir.
So is there any dogmatic way of proving that it's only Gilbert syndrome?
UGT1A1 deficiency can be tested, sir. Enzyme deficiency can be tested.
Postgraduates,
So he's giving us some clue. What do you see in liver biopsy? You do knowingly or unknowingly what
Doing it.
biopsy for Gilbert's?
do you do liver biopsy?
No.
Unknowingly or done a liver biopsy?
Ma'am? The bilirubin has normalized, ma'am. The patient...
I'll tell you.
Okay.
Actually, this is presented just to highlight the various ways by which patient come to you. So he came to us with severe anemia, then jaundice and high fever. So we looked at all the old records, and then with the diagnosis of Gilbert's is going around for about 8 to 10 years. But then it didn't fit the picture. Whatever he came to us with, it didn't fit the picture. He had some skin lesions also. It required a lot of blood transfusions, and then by the time we got all the things ready, everything was negative. But then we picked up that small round cells in the peripheral smear, but the pathologists refrained from telling that it is clear-cut hereditary spherocytosis. They said it looks like spherocytes, but we require to be investigated further. Then we decided to go on to genomic studies, and then we picked up that abnormal gene thing, and then everything fell into place. Then we looked back into parvovirus and found that it is one of the common viruses which causes marrow suppression. So this patient, though he had severe hemolysis, did not. Sorry, you have to occupy that. So he did not show the retic response. So it all fitted subsequently that because of parvovirus there was a marrow suppression. All the count, including your platelet, was low, and that's how we picked up. And then he subsequently improved. Once the virus settled, the fever settled, he showed improvement. He was not bleeding. The hemoglobin came up to 9. And we also discussed with the hematologist regarding splenectomy for hereditary spherocytosis, but then they said, it's all okay now, he's come back, let him come for follow-up. Bilirubin settled to around 2.5. We discharged him with follow-up. He comes on telemedicine to follow up, and it's doing well as of now. So
this case fits completely with spherocytosis. It fits well. Only thing why the sudden there is deterioration. That's the only point. Only thing we used to do an osmotic fragility test. You don't do. Huh?
No, ma'am, we haven't done it, ma'am.
That when you suspect hemolysis, you have to do an osmotic. That is one of the confirmatory tests for spherocytosis, even before your genetic test.
That's what we do.
Yes, ma'am.
we couldn't get any family. Yeah. But the spear, they were not very clear. That we need to test further and then confirm. COVID negative.
And spherocytes can be seen in any type of hemolysis. Any type of hemolysis, even autoimmune, you can have spherocytes.
Even post-transfusion, sometimes you can have
Anytime you can see
spherocytes. So you have to
spherocytes.
do your osmotic fragility, then only genetic if it is available. Any skin
That's why they
lesions-
said that they cannot definitely give a diagnosis of spherocytosis on peripheral smear. So we had to do the genetics.
Any skin lesions, because parvo can cause some skin.
He had the maculopapular rash, ma'am,
Sometimes
bilateral
we have dermal
lower.
erythropoiesis.
Yes.
Extramedullary erythropoiesis, blueberry muffin, what we see in children rarely.
I think we can go to the next paper. A rare pre-neoplastic lesion in stomach by Dr. K. Deepak, Apollo Hospitals.
A very good evening to one and all. Next topic is a rare pre-neoplastic lesion in the stomach, and under guidance of Dr. K.R. Palniswamy sir, we are presenting. So this is a 69-year-old female coming from Chennai, and she is a housewife. With chief complaints, actually she was evaluated elsewhere for an iron deficiency anemia and came to her hospital only as a reference for iron deficiency anemia. Regarding the symptom analysis, she had an history of heartburn. Other than that, there was no other any significant history like any blood or mucus in stools or any abdomen pain or any history of loss of weight or loss of appetite or any other cardiovascular symptoms or any history of recent fever or any history of early satiety. And regarding the past history, there has been a significant hypothyroid, diabetes and hypertension, which she also has a coronary artery disease and was on single antiplatelet since 2015. And regarding the surgical history, she has a long list. She has undergone 2 LSCS and a hysterectomy also was done later in view of menorrhagia. And she also had a right inguinal hernia surgery. And further, she developed even an incisional hernia because of that hysterectomy, and then she was operated twice for the same. So coming to general physical other history, like she was a non-smoker, non-alcoholic, and her bowel and sleep pattern were all good. And coming to examination wise, she was very conscious and cooperative, and she had a pallor alone, and there was no icterus, cyanosis, clubbing or any pedal edema, and rest of the vitals were all stable. So systemic examination, per abdomen was all, there was nothing significant. Inspection wise, other than the suprapubic horizontal scar, we are not able to find any significant other changes. And palpation and percussion and auscultation were also all normal, and it was not contributing to anything. So coming to blood investigation, in outside reports, based on outside reports, she had an hemoglobin of 8.1, which was done on 25th February. Then later it was around 7.9. Other than that, her electrolytes levels and INR and urea creatine were all normal, and CRP levels are also normal. And basic ultrasound was done, and liver, spleen, everything looked quite normal. So, in view of just an iron deficiency anemia under evaluation, we planned for an endoscopy and colonoscopy. And the endoscopy showed the following image. So, on forward view as well as on retroflexion view, we are able to see a large polyp which had multiple frond-like projections. And so, initially, we have taken an biopsy of this lesion. And since biopsy takes usually for 2 to 3 days, we immediately suspected her to do a CECT abdomen. And the CECT abdomen also showed the following image. As you can see, as you can see that there are large, in the body of the stomach there is a very large lesion which is having an associated hyperdense lesion also in between. This hyperdensity, and we can see enclosing complete, it is almost enclosing the entire body cavity. Other images also, and you can see in arterial view there has been a hyperdense lesion changes here, indicating that it is highly vascular also. So the CECT abdomen report, they gave us presence of a large irregular heterogeneously enhancing lesion with multiple frond-like projections in the proximal body of the stomach, measuring across 10 cross 8 cross 7 centimeter. And the mass is noted to also have a prominent vascular pedicle with along the greater vasculature of the stomach, greater curvature of the stomach noted to be invaginating along the vascular peduncle. So meanwhile, we got the endoscopy biopsy report also. And the endoscopy biopsy report from the mass which is arising from the fundus showed the presence of a pyloric gland adenoma with a serrated features and focal dysplastic changes. And antrum biopsy also was done and it was found to be negative for any atrophy or any H. pylori infection. So the next step, what we did, we decided to have a surgical consultation, and the surgical team, this is a biopsy findings. In the biopsy, you can see a prominent nucleoli here. As you can see, the cells are having many prominent nuclei along with the serrated features, as you can see here. And these are all closely packed glands. These are nothing but the pyloric glands which are closely packed together. And this is an endoscopic biopsy reports. And so the surgical team, they had suspected her to undergo a laparoscopic excision of the pyloric gland adenoma. And the intra-op findings was a large polypoidal mass of around 10 cross 10 centimeters noted along the greater curvature on the posterior aspect of the stomach. So they have done an small incision along the greater curvature of the stomach, and they have removed the tumor in toto. So after that, the biopsy specimen came back post-surgical as pyloric gland adenoma, which features a very high-grade dysplasia with a lesion not involving the submucosa or the muscularis mucosa. So the lesion has been confined within the mucosal layer, but with the presence of a very high-grade dysplasia. So this is the post-surgical resected specimen biopsy images, histopathological images. As you can see, there is a prominent nucleoli. Here you can also see the rounding of the nucleoli here. In this is a low power, this is a high power view. And all these changes are indicative of a severe pyloric gland adenoma. So coming to what is the pyloric gland adenoma, actually is one of the very rare tumor of the gastric mucosa, and it is most commonly located in the body or in the fundus, followed by antrum. It can be also be seen in your duodenum also and in the small bowel, but is very rare, and it is usually associated with an autoimmune gastritis and chronic gastritis. People tend to have an ANA positivity if they are presenting with an autoimmune gastritis. And regarding familial syndromes, it is seen in association with familial polyposis syndrome, Lynch syndrome, and in juvenile polyposis syndrome, as well as in the McCune-Albright syndrome. And regarding the genetic anomalies, what are the causes for the pyloric gland adenoma is the patient can have an underlying APC gene mutation or gene RAS or KRAS, along with the chromosomal abnormalities like gain in the 17pq or in 20q, as well as losses of the 4q and 6q chromosome structures. And the neoplastic risk will definitely increase if the patient is having an underlying associated autoimmune gastritis, or if there has been a very large polyp size, and if it is a tubulovillous pattern architecture, and even after completely resecting the specimen via endoscopy or via surgical, the patient has around a 10% risk of recurrence of this lesion. And who are all more susceptible are people who are elderly more than 45 years, mostly women, it is most commonly seen. As you see, our patient is also female. And predominant localization, the corpus mucosa, our patient also had in the body of the stomach. And the risk of malignant potential is around 12 to 46%. Our patient also had a high grade dysplasia, but it has not breached the submucosa or the muscularis mucosa. And endoscopically, it can also present like a polypoidal lesion or even as a mass-like lesion with some mucosal irregularities also, or even as an ulcer or a flat lesion. But most commonly, polypoidal lesion or a mass lesion will be seen. And if we happen to see a chance of a pyloric gland adenoma, it is indicative of doing an endoscopic polypectomy or by a surgical means, depending upon the polyp size and individual to individual basis, we can offer the treatment plan. And it is can also present like a dome-like lesion. And in histopathology, the unusual neoplasia is characterized by thickly packed pyloric gland type tubules lined by epithelium and composed of cuboidal to low columnar cells with a pale or an eosinophilic cytoplasm. And regarding further, to strongly correlate, there will be an expression of both MUC6 and MUC2. And MUC6 is a pyloric gland marker which is most commonly seen in the deeper portion, whereas the MUC5AC is most frequently found on the surface of the gland. And MUC6, if MUC6 alone is positive, then it has been associated with the pure pyloric gland adenoma. So the take-home message: what is the significance of pyloric gland adenoma? As you see, this gland can mimic like a malignant lesion. And so if the patient happens, by chance you are catching up the patient in a pyloric gland adenoma, we are catching up very early. Thereby they have around 12 to 46% risk of turning into a malignant potential. So that is the significance. And early identification is very essential. And one of the differential diagnoses of polypoidal lesion can be taken as a pyloric gland adenoma, though it is extremely rare. And the biopsy significance, as you see here, with an endoscopic biopsy, they are able to tell as a focal dysplastic changes. But as a whole surgical specimen which we resected and we saw, it was a high grade dysplasia. So the biopsy significance is also needed. So whenever we see a pyloric gland adenoma, it is essential that you remove as a whole without remaining any bits inside. And there is a role of surgery and endoscopic intervention. As of now, all of them it depends on case to case basis whether you can take them up for surgery or you can do an endoscopic intervention. It depends upon the polyp size, or it depends upon the friability of the patient also. So that is the take home message. Thank you.
Yeah, very interesting presentation, and very rare type of tumor which is presenting in the stomach. Yes. Most often we think whenever a bulky tumor comes, intra-gastric tumors, we think of GIST, or we think of a neuroendocrine tumor or an adenocarcinoma, whatever it is. But it's that too, the patient has presented only with anemia. There is no symptomatic. Such a huge tumor occupying the stomach, there was no features of gastric, any obstruction. No outlet obstruction. She didn't present with any fundus, but it looked as if it is almost occupying the body also. Yeah. So, have you searched the literature? How many such cases have been reported in the well literature?
Around a series has been made. Around 90 patients also have been made. Around a series also has been published in 2004, sir. Around 90 such patients have been taken for this. So, but though 90 patients, still extremely rare only.
What exactly was the surgery done? There seems to be a disparity between the endoscopic picture and the CT finding. Endoscopy shows it's a funding tumor.
No, starting from the fundus and occupying the entire.
CT shows a large bulky growth involving the body.
I have done the endoscopy. Endoscopically, it was a funding tumor. And the involvement of the body, it was not significant. So, but CT-wise, I think probably we see there looks like the involvement of the body along vesica curvature.
And what was surgery done, sir?
Surgery is a resection of the tumor.
And was it a sleeve resection of the stomach or a...
No, not sleeve resection. Only the resection of the lesion.
How it was done, sir? Because he told the stomach was opened.
Enterotomy was done and they just resected it.
They did a gastrotomy.
Yes.
After that, they saw the lesion. After that, was it a full thickness excision of the wall of the stomach along?
all of the, maybe I'm not.
Or it's just
I'm
a
not clear.
submucosal dissection or something like that.
They have not mentioned anything about submucosal, sir. They are just removed as in toto, that's all, sir. Since it is involving only the mucosal
No,
layer.
if it is removed in toto means they have to excise the full thickness wall of the stomach and suture it.
Yeah, I think it's a full thickness.
Yes, sir. Because then only you can comment about the deeper layers.
Yes.
And that too being high-grade dysplasia, the histopathological feature, so there should be a full thickness resection of the stomach.
No, I just want to know, in such cases, suppose you have encountered, would you have considered gastrectomy, subtotal gastrectomy or something? I mean, I'm just...
I would, in this such situation, I would do a sleeve resection of the stomach.
Okay. Dr. Shankar?
I would have done a, because high-grade dysplasia always indicates there is a lurking malignancy. But though they have shown there is no invasion, but I would have gone for something like a gastrectomy, organ-sparing gastrectomy. You can do a proximal gastrectomy.
Colonoscopy was
no,
not.
colonoscopy was, no. That was done subsequently, not at this time. And because of the surgeon, again, before taking up a surgery, he wanted a colonoscopy. Colonoscopy is normal.
There is a less than 10% chance of recurrence. 6 months once at least in the first year they need to go endoscopy. Then yearly once, then up to 3 years. As of for pyloric gland adenoma, they have not given one. You can follow the NCCN guidelines.
What about the, have you consulted the oncologist for any further course of treatment on this patient? No, but they said some high-grade dysplasia.
High-grade
dysplasia. The microscopic is high-grade dysplasia. It's a peak cancer. Almost it's cancer. High-grade means almost.
No, even imaging-wise, I mean, it was not like any sort of advanced status. Elsewhere, no spread was seen. And surgeon was confident. He just in toto, he removed the tumor. That's a bident. Maybe I think probably we should follow closely.
That was a nice presentation. We'll go to our next topic. I now invite Dr. Satvik for a presentation on toxic megacolon-associated Clostridium difficile colitis. Hope he'll stick on to the timing then.
Good evening, everyone. I am Dr. Satvik, first year resident from SIMS Hospital. I thank TNISG for giving me this opportunity. I will be discussing this case under the guidance of Professor Ramakrishna sir. So our patient, Mr. B, is a 54-year-old male who is a marketing manager by occupation, whose occupation involves frequent travel across various parts of the nation, came with the chief complaints of loose stools for 4 days, abdomen pain for 4 days, and abdomen distension for 2 days. So the patient had complained of loose stools for 4 days, which was acute in onset, 10 to 15 episodes per day, which was small volume, watery, Bristol type 7, which was associated with the passage of mucus, and there was no blood. There were history of nocturnal episodes and increased urgency, but there is no history of tenesmus. So the patient also had complaints of diffuse lower abdomen pain, which started along with the loose stool episode, which was acute in onset, progressive. It was spasmodic kind of pain, intermittent in nature, and it was not radiating or not associated with vomiting and not related to either food or defecation. So there was no history of any fever, no history of any loss of weight or loss of appetite, no history of any joint pain, redness of eyes or skin lesion. So past history of similar episode of loose stools was there 1 month back, where it lasted 5 days. It was small volume, had 5 to 6 episodes per day, watery. That time it was associated with blood and mucus, which settled with the course of oral antibiotics, which was prescribed by his family physician. He is a known hypertensive and hypothyroid under regular treatment, no other comorbid illnesses. Personal history, he consumes vegetarian diet, non-smoker, not an alcoholic, and no other substance abuse. On examination, the patient was well built and well nourished. There were features of mild dehydration. Heart rate, there was slight tachycardia. Blood pressure was stable. Temperature was 99.4 degrees Fahrenheit. So general examination, nothing was significant. Systemic examination, per abdomen gaseous distension was noted. Diffuse tenderness was present over the lower abdomen region. It was tympanic and percussion, and bowel sounds were sluggish. Other system examination was normal. So to summarize, a patient is a 52-year-old male who's a marketing manager by occupation with chief complaints of loose stools, abdomen pain and distension for 4 days with increased urgency and mucus in stools, who's a known hypertensive and hypothyroid with recent history of antibiotic usage with sluggish bowel sounds and ECOG performance status of 0. A syndromic diagnosis at this point is an acute onset large bowel diarrhea with probable ileus. Differentials at this point is infectious colitis, maybe acute gastroenteritis, antibiotic associated diarrhea, maybe Clostridium difficile associated diarrhea, or an index event of IBD. So coming to the investigations, complete blood count revealed leukocytosis with a neutrophilic predominance. Renal parameters were elevated slightly. Electrolytes other than hypokalemia, it was normal. CRP was elevated. Viral markers were negative. Liver function test other than hypoalbuminemia, everything was normal. Stool routine test was normal. Since the patient had an abdomen pain, distension and sluggish bowel sounds, we did a CT abdomen where there was a diffuse edematous wall thickening of the entire bowel along with dilation of the transverse colon and distal jejunal and ileal loops. The transverse colon diameter was around 66 millimeters. This is the CT report. So, since there was a recent history of antibiotic usage and after CT abdomen, we did a stool test for C. diff where all the GDH, toxin A and B turned out to be positive. We did a limited colonoscopy without any bowel preparation wherein we found multiple confluent yellowish white plaques on the background of edematous and friable mucosa around 30 centimeters from the anal verge. So his course in the hospital during admission, since his symptoms resemble that of an acute infectious diarrhea, we started him on ciprofloxacin and metronidazole. Later, when the stool for C. diff turned out to be positive, we started him with oral vancomycin 125 milligram 4 times daily. But since then his abdomen symptoms didn't improve as we expected and his abdomen distension progressed. On day 7, we decided to give the vancomycin in the form of retention enema, 500 milligram dissolved in 100 ml saline 4 times a day. But even after that his symptoms were static and there was no improvement in the abdomen distension or abdomen pain. So on day 10, we decided to give the vancomycin enema through a trilumina feeding tube which was inserted using colonoscopy and placed till the hepatic flexure. Even at this point, we considered the option of fecal microbiota transplantation wherein we screened his wife. Unfortunately, she turned out to be positive for enterotoxigenic E. coli. In the meanwhile, his symptoms began to improve gradually. And on day 15, his abdomen distension reduced and he was passing normal stools. And we put him back on oral vancomycin and he was discharged. So 1 month later, when he came for follow-up, we found ulcers in the cecum and in the transverse colon with biopsies reported as in the cecum, extensive ulceration with mild active inflammation and few large cells with inclusion like nucleoli, suspicious of cytomegalovirus infection. In the transverse colon, there were features of mild chronic active colitis. The blood test for cytomegalovirus turned out to be negative. Right now, we are treating him as a probable case of Crohn's colitis and he is currently on Pentasa. Coming to discussion part. The prevalence of Clostridium difficile infection across various studies in India is around 4 to 18%. So the main risk factors include increasing age, prior C. diff infection, and medications like antibiotics, chemotherapeutic and proton pump inhibitors. The most common antibiotics which cause are fluoroquinolones, cephalosporins. The second line agents like aminoglycosides, macrolides, it is rare. Renal insufficiency, IBD, malignancy and other immunosuppressive states are one of the significant risk factor. Prolonged hospital stay is one of the risk factor. And also contact with actively infected patients or carriers. So the clinical features, most of them they turn out to be asymptomatic carriers. Some of them may have features of mild to moderate diarrhea. Severe C. diff is nothing but during presentation, if the WBC count is more than 15,000 and serum creatinine is more than 1.5, as in our case, it is a severe C. diff infection. Fulminant is along with the severe C. diff, if there are features of hypotension, shock, ileus or megacolon, we call it as fulminant C. diff infection. The complications include dehydration, hypoalbuminemia, ascites, dyselectrolytemia, toxic megacolon, bowel perforation, sepsis, and finally death. So the diagnosis is mainly by tissue culture, enzyme immunoassay, and nucleic acid amplification technique. We can do a limited colonoscopy to look at if there is any background of inflammatory bowel disease. Histopathology, the classical picture is a volcano lesion where there is a focal area of mucosal ulceration along with the eruption of the necrotic debris. So this is the American Journal of Gastroenterology, where the diagnosis is mainly by GDH or nucleic acid amplification technique, which we use clinically. The main limitation of GDH is it does not distinguish non-toxigenic from toxigenic strains. The toxigenic culture and cell cytotoxin neutralization assay is not performed clinically. So the diagnostic algorithm is, if a patient with suspected C. diff comes, we either start with a highly sensitive test, either GDH or nucleic acid amplification technique. If it is negative, we rule out C. diff. If it is positive, then we proceed to a more specific test by testing the toxin using enzyme immunoassay. If it is positive, we confirm it to be C. diff. If it is negative, there are three possibilities. Either it's only colonization, or it is a false negative toxin enzyme immunoassay, or the toxin levels fall below the threshold of detection. Still, if there is a strongly clinical suspicion, then we can consider nucleic acid amplification technique even in GDH negative patients. So the treatment of non-severe infection is oral vancomycin 125 mg 6 hourly for 10 days, or oral fidaxomicin 200 mg BD for 10 days, oral metronidazole 500 mg TDS in low-risk patients. For severe C. diff, the treatment is only vancomycin and fidaxomicin. Metronidazole is not preferred. For fulminant C. diff infections, vancomycin 500 mg 6 hourly along with IV metronidazole. In patients presenting with adynamic ileus, vancomycin enemas are preferred. So when do we consider the fecal microbiota transplantation? In patients with severe and fulminant C. diff who are refractory to antibiotic therapy, it can be given either in the form of capsule, enema or colonoscopy. We can give that in 3 to 4 days intervals until the pseudomembrane settles. But finding a donor in our country is very difficult without any pathogens. So the definition of recurrent C. diff infection is within 8 weeks after an initial episode, if there is a recurrence of diarrhea and positive confirmatory test either by nucleic acid amplification technique or enzyme immunoassay, then for this recurrent C. diff infection, the preferred drug is tapering or pulse dose vancomycin, wherein we give 125 mg 6th hourly for 2 weeks. Later, for 1 week, we give 125 mg BD, then OD. Then every third day, we give it for 2 to 8 weeks. For second or further recurrences, preferred is fecal microbiota transplantation. Various trials have reported that fidaxomicin and bezilotoxumab is better in preventing recurrence. We need to be cautious in using bezilotoxumab in patients with heart failure. The dose is 10 mg per kilogram IV as an infusion over a hour. So the patients who are experiencing recurrence after first fecal microbiota transplantation, repeat fecal microbiota transplantation is preferred. Surgery is indicated for refractory, severe and fulminant C. diff presenting with toxic megacolon or perforation. So in patients with IBD, the treatment is vancomycin 125 mg 6th hourly for 14 days. The main thing to be noted is the immunosuppressive IBD therapy should not be withheld during a disease flare, and we must even escalate the immunosuppressive therapy if there is no symptomatic improvement. In pregnancy and lactation, vancomycin is the preferred drug. So the take-home message is only patients with symptoms suggestive of active C. diff infection should be tested, which is 3 or more unformed stools in 24 hours, Classifying the severity, the total count, if it is more than 15,000 and serum creatinine is more than 1.5, we label it as severe C. diff. Fulminant, as I said earlier, it is along with the severe C. diff if there are features of hypotension, shock, ileus or megacolon. So according to the American College of Gastroenterology guidelines, which was published in 2021, there is no use of probiotics in patients who are being already treated with vancomycin or who are experiencing a C. diff recurrence. We need to be judicious in usage of antibiotics. Strict infection control practices must be followed. Thank you.
How long he was taking antibiotics?
5 days.
Very short duration, and that too ciprofloxacin metronidazole, less likely. And he's an immunocompromised individual because he had CME colitis.
No, he didn't have any. He was only a hypertensive.
That's
No,
what.
yes, He had only hypertension and hypothyroid. No previous hospitalization also. This was the first time he came to the hospital.
Did you treat his CMV?
No, sir. It was negative, sir. We didn't treat.
Can it be primarily CMV colitis? You had only a short presentation, and I don't think you said that he was on antibiotics only for 5 days. There was no other risk factor. He was not prolonged hospitalization was not there, and he is immunocompetent. He is not even diabetic. So even for CMV colitis, there should be some evidence for your immunodeficiency, which he is not having. Was he treated as IBD at some point of time or other?
No, sir. He was
prior
not
to
having
that
any
thing.
history
No,
prior to
not
that.
like that.
To rule out any background of inflammatory bowel disease or any other type. Yes.
Yeah, that's a good question. Colonoscopy indication in such cases. Huh? Follow. No, I just want to ask. It's a toxic megacolon. Is colonoscopy indicated in such cases?
Limited colonoscopy can be done to rule out if there is any background of inflammatory
The
bowel
literature
disease.
says that you should avoid
Yes, sir. We did
in
without,
such patients.
without any bowel preparation, we did limited.
How do you qualify toxic megacolon? How do you say it is toxic megacolon? You said
Yes, sir.
megacolon.
Megacolon
What
is-
is your definition?
If it transverse colon diameter, if it is more than 60 millimeters radiologically, we call it as megacolon. If there is systemic features of toxicity along with that, we call it as toxic.
So you see it through a CT.
Yes, sir.
Another thing you said, you will only do surgery when there is perforation. Is it that?
So refractory to antibiotic therapy. And
No. Would you wait till the megacolon perforates, or would you do surgery before that? You should not wait. If the diameter of the colon increases, if the patient is toxic, they say you have to do a total abdominal colectomy with ileostomy, or at least you do a blowhole colostomy. Yes, something like that. So you should wait till the patient goes in for perforation. The morbidity and mortality goes very high in such cases. Yeah, open to the audience.
Yes, sir. Trilumina feed. Actually, for better penetration of the drug, we felt we placed the trilumina feeding tube till the hepatic flexure, sir. We thought for better penetration of vancomycin drug, even after retention enema, since he didn't have any improvement in symptoms as we expected, sir.
Now, what way that tube is different from the regular nasovaginal tube?
Same thing, sir. Same like nasovaginal.
Not same thing. There is difference. It has two orifices.
Okay.
One it is orifice is distal, where you can deliver at the hepatic flexure, and one slightly proximal in the distal colon.
So actually the learning point in this patient really was that he had ileus, he had paralytic ileus as well, which was seen by the distension of the small bowel on CT. And he had originally been given oral vancomycin, to which he did not respond. So the learning point really is that you have to give vancomycin enemas when there is paralytic ileus. That reflects in the guidelines now. And since he didn't, after a few days, he still hadn't responded. He had partially responded, but not fully. That's really why we went in and tried to deliver the vancomycin proximally. I think the trilumina was only because we only have trilumina nasovaginal tubes. We don't have the regular nasovaginal tubes in our hospitals.
So the first episode of blood and mucus, you think it was ulcerative colitis?
No, ma'am. No, ma'am. We thought it was a probable acute gastroenteritis only that point, ma'am. The second time she presented with this classical pseudomembrane also. We need to rule out whether if there is any background of inflammatory bowel disease. And that's why we did a limited colonoscopy.
You don't have features of IBD now. So
Now we are currently treating him as probable Crohn's colitis only.
again colitis. Why Crohn's? Why did but why don't you think the whole thing is acute severe ulcerative colitis? The second attack of ulcerative colitis presenting with C. diff.
No, the ulcers didn't look like ulcerative colitis. They were normal the follow-up showed punched out ulcers with normal mucosa in between. And so that's... There's no CMV.
No CMV.
There's no CMV. PCR is negative.
Thank you, doctor. It's a good presentation. Next, I invite Dr. S. Gokul from SRMC to talk on hyperacute liver failure in a child case presentation. Dr. Gokul, please.
Good evening to all. I'm Dr. Gokul, first year hepatology resident from SRMC. My guide is Dr. Shanti and Dr. Kani. So actually this patient was actually a reference from the PICU. So a 2.5-year-old female child hailing from Mangadu, Chennai. So chief complaints, he presented with complaints of fever for almost a week duration and loose stool since 1 day. So coming to the history of present illness, the patient was relatively asymptomatic 8 days back. Then she developed fever, which was sudden in onset, high grade, intermittent, and which was relieved on taking medication. So her mother has given her paracetamol syrup. She has not consulted a doctor, but she was on taking paracetamol syrup, about 10 ml twice to thrice a day, which is amounting up to 1 to 1.5 gram per day. She had history of nausea, no vomiting, history of loose stools prior to the day of admission, about 2 episodes of loose stools, watery in consistency, not blood stain, no foul smelling. She had history of discomfort on lying on prone position. History of decreased oral intake on the day prior to admission, also incessant cry on the night prior to the admission. No history of any abdominal distension, no pedal edema, no decreased urine output, no history of any jaundice, no history of cough, running nose or breathlessness, no history of any crying on maturation. And she was actually brought to the pediatric OPD on the morning of 24th last month. As she was lethargic, the consultant in the pediatric OPD has sent her to the ER. So at 10:25 a.m. in the ER, she had feeble pulse followed by posturing of the limbs, and subsequently she went into cardiac arrest. So CPR was started according to the pediatric ACLS protocol, and about 6 cycles of CPR was done over a period of 10 minutes. 2 shots of adrenaline was given through the intraosseous line, and finally return of spontaneous circulation was achieved. And the child was further intubated and shifted to the pediatric ICU. No past history of any seizures. She had an uneventful antenatal history. The natal history, she had a term birth, normal vaginal birth, with a birth weight of 2.9 kilos. She cried during birth. Postnatal history was also uneventful. She had attained milestones for age, immunized for age, consumes mixed diet, normal bowel and bladder habits prior to this episode. She is born of second out of third degree consanguineous marriage. She has an elder sister, 6 years of age, who is fully healthy. She belongs to the middle class, lower middle class, according to the modified Kupuzomi scale. And coming to the summary, a 2-year and 6-month-old female child of third degree consanguineous marriage presented with complaints of fever, loose stools, and lethargy, with history of supratherapeutic dose of paracetamol, developed cardiac arrest in the ER, was resuscitated, intubated, and admitted in the pediatric ICU. So at this time, the pediatric people, they have diagnosis of meningoencephalitis, and she was started on intravenous ceftriaxone and acyclovir. And also a viral infection they were suspecting. So coming to the general examination, she was moderately built and nourished, height of 90 centimeter, weight of 10 kilos. She had pallor, mild dehydration, no icterus clubbing lymphadenopathy epiledema, and patient was on mechanical ventilation with multiple inotropes. She was on adrenaline, noradrenaline, and vasopressin infusion, and was also on peritoneal dialysis. She was having tachycardia with a BP of BP was 115 over 77 millimeters of mercury on dual supports, adrenaline and noradrenaline at that time. Mean arterial pressure of 90 millimeters of mercury, and on mechanical ventilation. So coming to systemic examination, the cardiac examination was both heart sounds were heard. She was having tachycardia. Respiratory findings on auscultation, the air entry was reduced in bilateral basal region. CNS, pupils were reactive to light, and there were movement of limbs were present on painful stimulus. And per abdomen, there was a peritoneal drain was in situ. So coming to the investigation, on the day of admission, her HB was 6.5, severe anemia, for which the pediatric team has transfused PRBC, and it subsequently came up to 11.6 on the following day. And on the third day of admissions, she developed mild bleed through the RT tube, through the Riles tube, and through the ET tube, and her HB further dropped to 8.7. And subsequently, again, she was transfused, and HB was maintaining about 13 to 14. On admission, she was having leukocytosis, which was again ranging between 13 to 14,000 throughout the time of admission, and the platelet was showing a decreasing trend from 2.23 to 50,000. So coming to the renal parameters, at the time of admission, the bun and creatinine were almost normal, with normal electrolytes, and she was having severe acidosis with a bicarb of 5. And on the third day, she had the creatinine was almost double than the time of admission. She was going in for AKI. So at first I thought 1 mg per deciliter was normal considering an adult, but for a pediatric child, the normal creatinine is for age of 2 child is from 0.2 to 0.6. So she was having AKI on the third day. And on the 26th, in view of the AKI, she was started on peritoneal dialysis as well, and subsequently renal parameters improved. So coming to the liver biochemistry, at the time of presentation, she was having coagulopathy with an INR of 3.29, normal bilirubin, and the transferases, AST and ALT were elevated. About more than 20 times upper limit, AST was elevated, with hypoalbuminemia and hyperammonemia, with an LDH of 3,623. And subsequently, on the third day of admission, on 26, both the AST and ALT, they were peaked at about 19,000 and 7,000. And also, the coagulopathy also increased to 7.24, with again rise of bilirubin. And she had severe hyperammonemia of 534. So in view of the AKI, hyperammonemia, peritoneal dialysis, and metabolic acidosis, peritoneal dialysis was initiated. And following which, subsequently, over the period of 2 days, both AST and ALT has a significant drop as well. Okay. So coming to the ABG, at the time of admission in the ER, she was having severe metabolic acidosis with a pH of 6.777. with a lactate of 12.83 and bicarb of 5. And subsequently, it improved on correction. So the culture, blood culture, urine culture was negative. Fever panel was also negative. And the nasopharyngeal swab on doing a respiratory multiplex panel showed a positive adenovirus and Klebsiella pneumonia. And the hepatotropic virus was also negative. The chest X-ray showed bilateral pleural effusion and features suggestive of pneumonitis. Ultrasound abdomen, she was having hepatomegaly, 11.2 centimeters liver, mild to moderate ascites, a splenic hemangioma, and bilateral mild pleural effusion. Echocardiography, there was a functionally normal heart with sufficient pumping. So MRI brain, this was actually done on 28th. So it was showing features suggestive of hypoxic ischemic encephalopathy. So at this point, the differential diagnosis, I would say, patient is having acute liver failure, either due to basically having 3 hits on the liver, adenovirus, or drug-induced paracetamol poisoning, or ischemic hepatitis. So coming to paracetamol, the usual dose of paracetamol is 10 to 15 mg per kg per dose, given every 4 to 6 hours and not to exceed more than 5 doses. So in this child, she almost got about 1 to 1.5 grams per day. So according to this calculation, she is supposed to get 750 mg per day. And the single toxic dose is 150 mg per kg. That is almost, for this child, it will be around 1.5 gram as a single dose. Staggered overdose is 200 mg per kg over 24 hours in divided doses, or 150 mg per kg over 48 hours in divided doses, or 100 mg per kg over 72 hours in divided doses. So she was getting a staggered overdose of paracetamol. Also, she was positive for adenovirus. So adenovirus is relatively common, but liver dysfunction is actually rare. So it's mostly a self-limiting disease in an immunocompetent patient, but typically causes mild upper respiratory, gastrointestinal, and ocular infection in the immunocompromised, in the normal people. In immunocompromised individuals, especially in children, it can lead to significant morbidity and mortality. But there are cases of acute fulminant hepatitis from adenovirus that has been reported. And recently, adenovirus 41 type F, many cases has been reported in the US and UK during the last year, 2022, post-corona, COVID. So there are many cases reported in both US and UK. In this patient, they will have features, a prodromal stage, features of, they will have developed jaundice, then they will go in for acute liver failure. So most of the children were below 4 years of age. And about 70% of them are positive with adenovirus. Ischemic hepatitis, it is characterized by a rapid striking elevation of the aminotransferases and LDH, along with an equally brisk resolution of these parameters. So ischemic hepatitis is associated with predisposing pathological conditions like cardiac failure, circulatory or septic shock, or respiratory failure. And it is also described in the absence of any documented shock or hypotensive episode in almost 50% of the cases. So this child, she was positive for adenovirus. She was taking a staggered dose of paracetamol and also had arrest for and also had hypertension. She was on multiple 3 inotropes. So she had she had 3 of these: adenovirus, ischemic hepatitis, and a staggered overdose of paracetamol. So the probability of spontaneous recovery. So most important factors for predicting the outcome in acute liver failure are the degree of encephalopathy, the age of the patient, and the cause of the acute liver failure. So these factors in part reflect the importance of the severity in the hepatic injury and the likelihood of reversal, either spontaneously or with specific therapy. So in case the grade of NCAF is lower, grade 1 to 2, they have 60 to 75% of spontaneous recovery, grade 3, 40 to 50%, and grade 4, less than 20%. And the short-term transplant-free survival rate for ALF overall is 43, and transplant-free survival rate is more than 50 in patients with ALF due to paracetamol, hepatitis A, ischemia, or pregnancy-related acute liver failure, while it is less than 25% for patients with ALF due to hepatitis B, autoimmune hepatitis, Wilson's disease, Budd-Chiari syndrome, cancer, or any other indeterminate cause. So indication of PLEX. So patients with ALF and acute and chronic ACLF, they have high short-term mortality rate. So the PLEX has improved the survival rate in these patients who are not undergoing transplant. Contraindications: patients who cannot tolerate the central line placement, sepsis, hemodynamic instability, allergic to FFP, and albumin. So indication of dialysis in this patient is AKI, hyperammonemia, and severe metabolic acidosis. So actually this patient was considered for transplant, but she was not fitting into the King's College criteria for transplant. So the take-home messages: adenovirus 41 type F has been reported to cause ALF in pediatric age group less than 4, and in many cases has been reported in US and UK after the COVID pandemic, and you should be vigilant for the detection of ALF in adenovirus infection. Thank you.
So we are having a lot of clusters of adenovirus recently in children. And the 3 confounding factors, as you mentioned, drugs plus infection plus ischemic or hypoxia injury.
Yes, ma'am.
So that is the reason the child had acute liver, hyperacute liver
Hyperacute
failure
liver
and
failure.
succumbed to the illness despite your conservative, whatever the management.
So I think there were several atypical features here. I didn't see the INR, perhaps.
2 points, more than 2.5. 2.9.
Okay. So on the day of admission, it was around 3.29.
Yeah. So the bilirubin never went very high, and the enzymes were very high. Why is it not a Ray's syndrome?
Ray's syndrome.
No, okay, aspirin was not there, but you don't have to have aspirin to have Ray's syndrome. Dr. Malati can comment.
He's clearly shown that, acute liver failure in that age can be multifactorial. I think step by step. And this recent adenovirus outbreak has been reported as severe acute hepatitis, US, UK, and in India.
Yes.
Delhi, they have reported now, I think they'll be publishing their paper, and the babies have, like you said, less than 4 years. What is happening is, a virus which was so common and just producing a respiratory infection in children, this COVID has changed the immune mechanism of, that is the hypothesis. And it is making even a virus which should not behave like this, so maybe we will not see this cluster again after some time. Like we saw COVID pancreatitis, now we are not seeing again. At that time we had a cluster. Now we are seeing this severe acute hepatitis with adeno, very sick. And it's very sad also. And that, like you said, it's a therapeutic misadventure we call. Parents are so anxious. And the bottles are, one is 500 milligram, one is 250. The drops are more concentrated. Like you said, why bilirubin is not going up? Even in herpes, when you get, sometimes you don't get, the bili going up, but transaminase is going up. Ray, usually the sugar, this thing, the liver he didn't mention. I was waiting for a hepatomegaly. I was also thinking he would tell that underlying metabolic liver disease was there and it came up. I was also hoping you would be telling about something like that, because you went it very like a missed story. You told about the pulmonary, you told about everything, and you brought the liver last.
And then there was consanguinity also.
So he was telling all that. So usually in a 2-year, when they come, we always think whether they had an underlying thing, like, a fatty acid oxidation or an organic aciduria coming up. But very well presented, because I think you brought out that adeno, so sick, very sad, that hypoxic injury and that marked elevation which we see in hypoxic. I think you brought that out also very well.
Okay.
But I think transplant would have done. What happened?
Child died. It's
very sad. Very sad. But I think by the time the brain.
Multifactorial, child had cerebral edema, hypoxic ischemic encephalopathy.
Yes, ma'am.
Child was given NAC.
They gave NAC.
She was brought in a very moribund state.
After 8 days of your paracetamol, it's too late presentation, even for infection, adenovirus, whatever the swine flu, you have to give treatment as considered even before 5 days. When the fever is not getting settled within 72 hours, we should be very careful in children, especially in the recent outbreak, whatever it is of flu virus and even this adenovirus. So after 3 days, fever is not getting settled, better to have a continuous monitoring of this young infant especially.
Just to add something, this child I think was delivered in SRMC where all the children delivered in SRMC have got a metabolic panel at birth. Metabolic panel 1 and 2, so it almost rules out most of the underlying IEMs. Also, this is just, the main highlight is UK and US, I think still a collaborative task force is going on regarding adenovirus. And so 27 countries are actually still evaluating. So they're looking at the genetic susceptibility of these children, whether they've got anything underlying, whether COVID is predisposed, or whether these children who have not been exposed during the pandemic to any infection at all. So because of the adenovirus, is there a different wild variant of the adenovirus, just a different strain of the adenovirus? So many theories are floating. They've actually, the North American, Pediatric Gastroenterology Association has given the task force has given several working hypotheses, it's still ongoing. This is, I think, mainly to highlight the adenovirus, and I think Gokul is the first year PG, I think, for that.
Some of the children will have even conjunctivitis, just a red eye with watering. That's one of the clinical.
Okay, so there's no epidemiological clustering around SRMC from what we heard actually.
Some clusters of cases were reported, and we also had some cases.
There are quite a number of positive adenovirus cases, but not in general.
He's talking about Plex, not me. First of all, very well presented. This is a very sick patient, and you brought out many factors. I had two thoughts to think about. One is, if we say liver transplant is not possible or not feasible in whichever way, then can we make survival in any other way better? So the two things we would consider is, one is Plex, which I will come to, but before that the question is about sedation. The question is, should we sedate this child or not? Let's say the child is already flat out. Should I sedate further? Is one big question. Now, most sedative drugs, or maybe all sedative drugs, are metabolized by the liver. And already there's liver failure, liver is not functioning well. So it's like the first therapeutic misadventure. It's possible, this has not been studied at all really, that if we check sedative levels, and let us say we give somebody midazolam or Dexmed, this patient's Dexmed levels will be higher. In fact, we are now embarking on that in a bigger way in CMC. The first data set is going to come out now. So the question is, why sedate? So now this child is flat out, okay? This child starts to move around a little bit, everybody is a little more happier. Only problem is, ventilating would be a challenge. That's the challenge in the person who's on a ventilator. So that is one big difference. So in CMC it's easy because most patients who come, they are not opting for liver transplant, for an urgent transplant. That is not coming in on the plate. So then we explain that and we clarify that they are not opting for an urgent transplant. Then we start raising the question, why sedate? So this is something you have to go back and look at your own records. Did this child get sedation? Now the child is already in liver failure, and does the child merit sedation or can we manage without sedation? I'm not saying it will change anything, but who knows, it may change in some patients. You may start finding some. So that's also encephalopathy in that. So then the question is, what are the indications for sedation and what should we continue with sedation? These are all serious questions, and there are data guidelines on that as well. I'm just sensitizing ourselves. Secondly, if we sedate, should we give the regular dose of sedation or a smaller dose of sedation? So we've started moving towards that, and we are saying, if we sedate, and there are indications of sedation, then let's start doing maybe the smallest dose. So what are the smallest dose? So maybe 1/4 the dose. So I'll stop with that. I'm not opening up Plex, that's another topic by itself, but I just want to sensitize here to question about not to sedate is something to think about. Thank you.
Thank you, Doctor.
Thank you.
The next we move on to review of Indian Literature, Episode 1, Management of Ulcerative Colitis. The speaker is Dr. R. Santosh. Dr. Santosh, please. From MMC, Madras Medical College.
Good evening, everyone. I'm Dr. Santosh. I'm third year medical gastro resident in Madras Medical College. My guide for the topic is Dr. Shubha. My topic is Management of Ulcerative Colitis, Review of Indian Literature. I'll be discussing about treatment of acute mild to moderate ulcerative colitis, acute severe ulcerative colitis, maintenance, diet, pregnancy, and colorectal cancer and its surveillance. So, acute mild to moderate ulcerative colitis, induction is usually done with 5 aminosalicylic formulations at the first line. So, extent of involvement of colon usually decides the treatment regimen whether to go for topical or oral or both. In case of proctitis or left-sided colitis, topical treatment has an advantage. We have shorter time to response, less frequent dosing, and less systemic absorption. So recommended dose for topical therapy for suppository for induction is 1 gram once daily. Mesalamine enemas are useful, and a dose of 4 gram or more is more successful than steroid enemas. Patients not responding to topical therapy can given a combination of both oral as well as topical. Topical steroids can be added for those not responding to both. So in extensive ulcerative colitis, a combination of topical and oral formulations are preferred over oral alone. Doses of 2 to 4.8 grams per day should be given in induction. Once daily dose is effective, as the new multimatrix formulations can be given in a single dose. Sulfasalazine can be considered in patients with concomitant arthralgias or arthritis. a period of 2 weeks of therapy should be given before considering them as a non-responder. So they are effective usually in 80% of patients within 2 to 4 weeks. So failure of disease to respond within 2 weeks to mesalamine or development of any intolerance, steroids can be considered. Oral prednisolone 40 to 60 milligram per day should be started and to be continued till significant clinical improvement is achieved. Tapering is done at 5 to 10 milligram weekly until a dose of 20 milligram is reached. After then tapering is done at a slower pace of 2.5 milligram per week. Shorter course are associated with early relapse, or a dose of prednisolone less than 15 mg per day are usually ineffective to treat an active disease. Maintenance of mild to moderate ulcerative colitis. Long-term 5-ASA is indicated in maintenance. In mild to moderate ulcerative colitis, dose used for induction should be continued for initial maintenance. Dose reduction can be considered in patients with mild clinical course with complete mucosal healing. Steroid-sparing agents should be given if the use is more than 3 months. Fecal microbiota transplant. So it has been evaluated in maintenance or induction in mild to moderate diseases. The logic is patients with ulcerative colitis have a dysbiotic microbiome, but it is unclear if this is a marker or driver of the intestinal inflammation. In a pilot study by Dr. Sood, a randomized control study, he evaluated the role of FMT in maintenance in ulcerative colitis with mild to moderate disease in 61 patients. Steroid-free clinical remission was a primary outcome with Mayo score less than 2 at week 48. And the primary outcome was achieved in 87%, that is, the 27 patients out of 31 had achieved a maintenance. Another study by Kedia et al., a randomized control study, in which FMT with anti-inflammatory diet was used in induction and maintenance of clinical remission with anti-inflammatory diet alone in mild to moderate disease. So the primary outcome was SECAI less than 2 or UCEIS less than 1 at 8 weeks and a steroid-free clinical remission at 48 weeks. So FMT with AID was superior in inducing remission at 67% compared to standard medical therapy at 8 weeks. Standard medical therapy being mesalamine. Multi-donor FMT was used. They were rural donors, and it was effective in inducing deep remission, and remission was sustained with anti-inflammatory diet alone for over a year. Now, looking at acute severe ulcerative colitis, usually infections have to be ruled out and toxic megacolon as well. IV steroids are indicated for patients with severe disease activity. Methylprednisolone is preferred to hydrocortisone owing to its less mineralocorticoid activity. IV steroids usually respond well, but they have failed in 38% of patients, and these patients require rescue therapy. There is no role of mesalamine in acute severe ulcerative colitis unless there is a high frequency where a topical mesalamine can be used. The response to IV steroids is traditionally assessed by Oxford criteria on day 3. Kedia et al. Recently had showed UCEIS more than 6 at baseline and day 3 fecal calprotectin more than 1000 microgram were independent predictors of IV steroid failure. So an Ames index was formulated based on these two parameters. A score of 0 almost rules out chances of steroid failure, and this Ames index was prospectively evaluated in comparison to Oxford criteria, and it had showed 100% specificity versus 83% specificity of Oxford in 39 patients with acute severe ulcerative colitis. So what are the rescue therapies available? Infliximab, biologicals, biosimilars, cyclosporin, and colectomy. Infliximab, a dose of 5 mg per kg, IV is given at weeks 0 to 6 as induction for rescue therapy. Another recent study, Mahajan et al. Had showed of 137 patients who received IF infliximab induction, 56.2% achieved clinical remission. A prior screening of HBV, HCV, TB, and HIV are required. Cyclosporin in management of acute severe ulcerative colitis. Doses of 4 mg per kg per day have shown a good clinical response in patients with steroid refractory disease. Sood et al. Had showed in 24 patients of acute severe ulcerative colitis treated with a dose of 4 mg per kg cyclosporin avoided colectomy in 79% up to 38 months of follow-up. A similar response was also seen in 2 mg per kg per day dose. The response rate with IV cyclosporin varied from 76 to 85%, with median time to response being 4 days. So the major limitations are its side effects. Major side effects are seen in up to 17% of patients, including seizures, neurotoxicity, hypertension, and renal failure. Minor side effects occurred in 31 to 51%. It included tremors, paresthesias, altered LFT, and gingival hyperplasia. Even therapy-associated death have been reported in 1 to 3%. So infliximab biosimilar. This is a retrospective study conducted by Kumar et al. It compared the efficacy of infliximab and infliximab biosimilar in 55 patients with ulcerative colitis. In biosimilar group, clinical response and remission rates at week 14 and 52 was 68 and 62%. In infliximab group, it was 66 and 56%. The response is comparable. 24% developed side effects in this. TB was seen in 18 patients, of which only one patient received biosimilar, 17 received infliximab. Adalimumab biosimilar, Kamath et al. Another retrospective study found in 21 patients with acute severe ulcerative colitis, it was effective in inducing remission at 8 weeks in 53% of patients, of whom 33 maintained remission over 1 year. Again, reported complications of 28.6% like TB, skin rash, and leukocytic vasculitis. Maintenance of acute severe ulcerative colitis, depending upon treatment, infliximab or cyclosporin. In infliximab group, with adequate response at 2nd and 6th week, maintenance is achieved with repeat dosing with every 8 weeks with azathioprine. As long-term use of biologicals is limited by high cost in the country, an alternative maintenance was evaluated with azathioprine and 5-mesalamine by Mahajan et al. They call it the miracle study. It is maintaining infliximab-induced clinical remission with azathioprine and 5-ASA in acute severe steroid refractory ulcerative colitis. 137 patients were included in this study. They were all induced with infliximab. After week 6, they were given they were continued with only azathioprine and 5-ASA. Cumulative steroid-free sustained clinical remission was maintained in 68%, 59%, 42% and 35% of patients of year 1, 2, 4 and 6 respectively. 67 relapses were seen in 33 patients and 67% occurred within the first 2 years. 2 relapses were managed with reintroduction of infliximab and 1 eventually required colectomy. All others responded to repeat course of steroids. So annual per capita maintenance therapy was much cheaper compared to infliximab group. So other maintenance therapy with cyclosporin group, adequate response at day 7 is evaluated and it has to be switched to oral cyclosporin 4 mg per kg per day twice daily. And azathioprine should be added at day 7. Cyclosporin should be stopped after 3 months. Immunomodulators usually decrease the colectomy rate when given along with cyclosporin. Cyclosporin in patients who are already on immunomodulators at admission showed higher rates of colectomy, hence it should be avoided. So dietary recommendations, these are based on the Asian Working Group Task Force guidelines in 2019. So for admitted patients with acute severe ulcerative colitis, adequate caloric intake is preferred to bowel rest. After stabilization of acute severe ulcerative colitis, a standard diet should be gradually introduced and oral nutritional supplements should not be a routine. Once in remission, there is no need of diet modification or restriction and patients can continue normal diet as other family members. So no dietary item is still established to cause relapse of disease activity in patients with remission. A low FODMAP diet may help in patients with symptoms like IBS. A gluten-free diet again is not of proven value in patients with IBD. Milk should not be routinely restricted in all patients with IBD unless patient has severe hypolactasia. So oral curcumin, it is an active ingredient of Indian herb turmeric. KD et al. Conducted a RCT with oral curcumin of 150 milligrams per day, thrice dose with mesalamine for its role in induction in mild to moderate disease. This was also a randomized control study and at week 8 that showed no difference in rates of remission in comparison with mesalamine and placebo group. Another recent meta-analysis by Saurabh Chandran et al. It included 7 studies. It showed a 3-fold better odds of a clinical response compared to a placebo with minimal side effects. So maybe the optimal drug dosage, drug delivery and durations are still its limitations. Out of the 7 studies taken, 1 had given rectal curcumin which showed a very high response rate. So surgery in ulcerative colitis, the traditional indications are colonic dysplasia, carcinoma or colonic perforations, growth retardation, intolerable or unacceptable side effects of medical therapy, medically refractory disease, systemic complications that are recurrent or unmanageable. So Mehta et al. Had showed that restorative proctocolectomy with IPAA as a procedure of choice done in a staged manner for elective procedure. Subtotal colectomy with Hartmann rectal pouch and end ileostomy is considered for emergency procedure. Now there is a shift in trend from open to minimal access procedures. Complications from IPAA such as pouch failure, small intestinal obstruction, and Crohn's disease of pouch are still some of the challenges. In pregnancy, it usually requires a multidisciplinary approach. If a new medication is started to treat active disease, it is recommended to wait for 3 to 6 months before conception. With active disease, there is a risk of preterm delivery, low birth, weight and spontaneous abortions, so pregnancy should be considered in remission. Scopy can be done usually in second trimester, but if the need is urgent, it can be done in any trimester. So patients who flare while on oral mesalamine can be started on steroids. There is a risk of cleft palate in first trimester and gestational diabetes. Budesonide MMX can be used when steroids are needed. If it doesn't respond, anti-TNF are preferred owing to its extensive safety data. So another study, Puri et al., a retrospective study, had suggested extent of disease as a major outcome predictor of pregnancy. In a group of 43 patients, patients with pancolitis had a higher rate of spontaneous abortions, low birth weight, and frequent and preterm birth. Frequency of C-sections and disease relapse was also higher in the pancolitis group. Colon cancer and ulcerative colitis, the risk factors, duration of more than 8 to 10 years, anatomic extent of colitis, PSC, early age of onset, family history of colorectal cancer, male sex, histologically inflammatory activity, colorectal strictures, and pseudopolyps. So Bopan et al. Had assessed the risk of CRC in patients with ulcerative colitis over a long-term follow-up. It was a retrospective and a prospective study. A total of 1,012 patients were included in this study. A cumulative risk of developing CRC was 1.5%, 7.2%, and 23.6% in first, second, and third decade of life, respectively. Of 136 cases which were evaluated prospectively, 3.6% had CRC on their screening colonoscopy. So the disease duration and increasing age were associated with a higher risk factor. A low risk of sporadic CRC in general population does not confer a low risk of CRC in ulcerative colitis. An incidence of sporadic CRC is higher in Western population, but incidence of CRC in ulcerative portions are also similar. A summary, a total of 1,085 Indian patients of ulcerative colitis were included. I've included 3 RCTs, 4 prospective studies, 3 retrospective studies, 2 meta-analysis, and 3 consensus statement. These are the following studies that I've taken. 5-ASA is usually the drug of choice in mild to moderate disease activity. It can be either topical or oral. Suppositories are the first line in proctitis. Topical mesalamine is usually superior to topical steroids. A dose of 2 to 4.8 milligram per day is given for oral. If you're giving a multimatrix formulation, a single dose is sufficient. Sulfasalazine can be considered in concomitant arthralgias. More than 15 milligram of oral steroids are required to treat active disease. A steroid-sparing agent should be considered once treatment duration is more than 3 months. Azathioprine is an effective steroid-sparing agent. IV steroids, possibly MPS, should be the first line for severe disease. Modest failure rate up to 38% have been associated with steroids, IV steroids. Ames index, newer index, could be an alternative to Oxford criteria, but its limitations being fecal calprotectin is expensive in our country. Infliximab or cyclosporin therapy have been an effective rescue therapy, and they have been traditional rescue therapies. After response to induction, infliximab can be maintained with azathioprine and mesalamine, and subtotal colectomy and Hartmann rectal pouch and endoleostomy is considered for emergency. Restorative proctocolectomy with IPA is for elective. Fecal microbiota is promising, but limitations include effective donor specimen for best response. Even some Western literature report of a super donor, they have a higher response rate than other donors. So optimal dose, frequency, and intensity of administration of FMT is still unclear, requires further investigation. Predictors of response is also lacking. So biosimilars have shown good results as a rescue therapy. More prospective studies are required for its use. As it is cost effective, it could be more useful in our developing nation. So turmeric, it still requires more evaluation whether it's useful. And extent of disease usually predicts a chance of C-section in pregnancy. So regular screening with random biopsies is warranted for colon cancer screening. A time interval between each screening and colonoscopy should be individualized for each patient based on their extent of disease, disease duration, presence of pseudopolyps and strictures. Thank you.
Very extensive and exhaustive presentation. Yeah. When do you consider budesonide when you compare to the prednisolone? Some people use that and this, but when do you consider when you want to use steroids?
So in case of
budesonide.
In case of maybe mild to moderate disease, budesonide can be given for a 9-week duration, a shorter duration than oral steroids. And MMX formulation are preferred in ulcerative colitis. Sir.
Any other questions from floor, sir? So you talk mostly about your step-down therapy, step-up therapy. Is there any Indian literature which favors step-down therapy? You start with your biologicals and then go for this thing.
In other words, where do you start your biologicals? In which case, as a first-line drug?
Ma'am, in severe ulcerative colitis.
Severe ulcerative colitis.
Or moderate ulcerative colitis.
Any questions from the audience? I now invite our secretary, dynamic secretary, to say his report. Dr. Brahma sir, he's at the back.
Thank you so much for the introduction. I think we've come to the end of the first session of postgraduate presentation. The only request is that to all postgraduates to come a little early. I find a lot of people actually walking in a little later. My earnest request is for them to be a little early, so that is mainly of use to them. First session. Now we move on to the secretary report, please. And I think thank again the MMC for taking up this first edition of this, taking Indian literature review. I think it was quite interesting, and I hope we can refine it further and we can take it, make it better. And I hope they submit this as a manuscript for our journal. Thanks. Secretary. Thank you. So first meeting, I'm still learning the ropes, and I hope to have your cooperation in taking this further the next 2 years. At the outset, I would like to congratulate and really have a standing ovation for the wonderful conference that we recently had at Trichy. I think we should give a big ovation to the organizing team for making this happen. I think Dr. Ubal is Dr. Prem Kumar, Patron, and Dr. K.R. Palniswamy are all here, and to all of members who have made it a grand success. I think, and Dr. Ravi and Dr. Chanduran being the local host have done a wonderful job. Very memorable conference, and think it is matching to all our national or even international levels. Moving on, I think as part of a multi-center study, I think Tamil Nadu ISD is, right now we are doing we have initiated, I think, a plex study. I think more probably we'll have more in the pipeline in the next few months. And at this point, I think it's a matter of a great proud moment for us. Like 3 members from our Tamil Nadu ISG have become deans of medical colleges in Tamil Nadu. I think Dr. Arvind is here he's become dean of Tirunelveli Medical College. May I request Dr. Palniswamy to honor him with a shawl, please. And Dr. Revati has become a dean at Omandarar Medical College, and Dr. Narayanaswamy at Kilpak Medical College. I think a round of congratulations to all. As part of new initiatives, I think this month on we have just started a Indian Literature Review as part of a monthly CME. Hopefully it takes better. And probably the next few months, probably we will have an additional, we are just thinking out whether we can have an online CME which will include people from particularly the teaching colleges and institutes in the different parts of Tamil Nadu, like outside of Chennai also. Probably they will also get some opportunity for them to present, and we will also have an opportunity to interact with them. So we'll work on that aspect shortly, and we'll get back to you with that. The key forthcoming meetings in this will be, we have an Endocon coming up in July. Our midterm TN ISG will be in September, possibly second week. The dates are yet to be finalized. And our national meeting probably in second or third week of December. I think I'll hand over for the next part. It will be the CME part. I'll request the moderators, Sir Dr. B.S. Ramakrishna and Dr. Basumani to come over and conduct the proceedings, please. Thank you so much.
I invite Dr. Gokul, consultant at Med India Hospital, to take the protagonistic role, game changer. Over to you, Gokul.
So, good evening, everyone. At the outset, I would like to thank Tamil Nadu ISG for giving me this opportunity to talk on whether this pre, pro, and postbiotics is just a game changer or a gimmicks. So, probably this interest in this topic is because there is a growing interest in the global probiotic market. It's expected to show a significant growth in the next few years. It is predicted that the market value will be around $85 billion in 2027 from the current $57 billion. And even Indian probiotic market is expected to show a significant growth rate. An interesting fact is that the National Health Survey found that in US, 1.6% of the US adults were using probiotics in the past 30 days, next only to vitamins and minerals. The mention of probiotics in ancient times was noted in the Indian Ayurvedic scripts dating from about 6000 BC, where the health benefits of consuming fermented milk products were mentioned, and even the book in the Bible, the book of Job, Abraham owed his longevity and fecundity to yogurt consumption. Now, not until Eli Meshnikov introduced the concept of probiotics, where he postulated that the yogurt-consuming Bulgarian peasants live longer lives, and for that he was awarded the Nobel Prize in Medicine in 1908, along with Paul Ehrlich. Now, the definition is very important. The WHO definition 2001 says that probiotic are live microorganisms that, when administered in adequate amounts, confer health benefit on the host. So not even spores are considered, strictly speaking, as probiotics. A prebiotic is actually a substrate for the probiotic. It's a selectively fermented ingredient that results in specific changes in the composition or activity of the GI microbiota, conferring health benefit upon the host. Now, typically these are polysaccharides and oligosaccharides that are non-starch in nature, either available in nature or produced commercially. So these are the common examples: oligofructose, inulin, or the lactulose. For example, this oligofructose in the colon causes increase in the number of bifidobacteria in the colon, increases calcium absorption, a lot of other beneficial effects. Now, a synbiotic means it's a combination of pre and a probiotic, a mixture comprising a substrate and a microorganism. It utilized by the host microorganisms to confer a health benefit. It can be complementary, meaning that individually the pre and probiotic can be beneficial, or it can be synergistic, meaning that the prebiotic is taken up by the co-administered probiotic and it exerts a beneficial effect. Now, simply saying, prebiotics are the substrate for the probiotic, which are live microorganisms, and the metabolites are called as postbiotics. Now, these postbiotic means that many of the probiotic and the prebiotic which we are using in clinical practice, they exert their effects or eventually act via the production of short-chain fatty acids, as well as the components like the microbial fractions, the polysaccharides, etc. So these are what are called postbiotics. A number of other terms have been mentioned in the literature, like paraprobiotic, which means that they are inactivated microbial cells, or metabiotics, meaning that they are components of these microorganisms. Now, the postbiotics act by a variety of mechanisms, like it can produce antibacterial substances like bacteriocins, or it can prevent biofilm by its production of teichoic acid. It prevents adhesion of pathogenic bacteria by lectins, and a lot of other beneficial immune mechanisms has been described. Coming to probiotics, the common formulations can be either single probiotic or a composite ones, like what is shown in this picture. The normal flora, we need to know about the normal flora functions. It has colonization resistance, meaning that it forms a barrier between the pathogenic bacteria and the colonic epithelium. It synthesizes vitamins. It is supposed to be the gut brain because it functions in signaling the bidirectional signaling between the brain and the gut microbiome. And also it ferments indigestible carbohydrates to produce short-chain fatty acids, which is a very important source of energy for the colonic epithelium. Now, common GI indications where these probiotics are used in our clinical practice. So, majority of my talk is taken from this World Gastroenterology Organization guidelines on pre and probiotics. I'm very glad to see that one of our professors, Professor BSR, is one of the review team of this article. Now, coming to levels of evidence based on, how these studies are, how important and what significance we need to give to these studies. We have level 1 evidence, meaning that they are from systematic review of RCTs. We have level 2, which means they are randomized controlled trials without a systematic review. 3 would be non-randomized control studies, and 4 will be from case series or case control studies, and 5 from mechanism-based reasoning. Now, coming to the first indication, the infectious diarrhea. Studies have shown that in children, it is beneficial, especially the Lactobacillus rhamnosus GG. We have 8 RCTs involving close to 1,000 participants. Significant reduction in the diarrhea duration, especially those of rotavirus etiology. The risk of diarrhea lasting for more than 7 days is reduced, and it also reduces the duration of hospitalization. Coming to the role of Saccharomyces boulardii in children, 9 RCTs involving 1,100 patients. This is the age group, dose, and the duration of treatment. The use is associated with a significant reduction in the duration of diarrhea by at least 1 day. Now, even the ISPAGAN and the European Pediatric Infectious Disease Guidelines went on to recommend that the Saccharomyces boulardii or the Lactobacillus GG administered in appropriate dosages may be used as an adjunct to rehydration therapy in the management of AG in children. Now, coming to acute infectious diarrhea in adults, the evidence is not that robust, but studies have shown that Lactobacillus paracasei is very beneficial compared to Lactobacillus GG in terms of reduction of the abdominal pain and the duration of diarrhea. Even Enterococcus faecium SF68 strain has been found to improve the diarrhea by reducing the duration of symptoms. Coming to traveler's diarrhea, in prevention, we have this meta-analysis of 12 RCTs involving 5,000 participants. The relative risk is 0.85. There is a 15% reduction relative risk of developing, less risk of developing traveler's diarrhea when you co-administer probiotics. The recommendation is to start probiotics 2 days before travel and to continue throughout the trip. Coming to antibiotic-associated diarrhea, we have this study which is for prevention of antibiotic-associated diarrhea in children, a Cochrane review of probiotics, 23 studies involving close to 4,000 participants. The absolute risk reduction is 11% when you use probiotics to prevent it. Either Lactobacillus rhamnosus GG or Saccharomyces boulardii, the dose of more than 5 billion colony-forming units per day. Similarly, this one more study of antibiotic-associated diarrhea in children and adults, a meta-analysis of 63 RCTs. There is a statistically significant association, reduction in the incidence of antibiotic-associated diarrhea when you co-administer probiotic. Coming to Clostridium difficile diarrhea prevention, treatment, it doesn't have any role. For prevention, we have this study of 31 RCTs involving 8,000 participants, Saccharomyces boulardii or Lactobacillus acidophilus. In this particular mentioned dose, prevents this C. diff diarrhea, but the number needed to treat is little high. It is 42 patients. And the subgroup analysis showed that those with higher baseline risk of developing this C. diff diarrhea, they benefit most. Coming to H. pylori infection, co-administering lactobacillus-based probiotics has been found to improve the eradication rates, and this is based on 11 RCTs of 700 patients. The elimination rate is in the lactobacillus supplement group compared to control group is the relative risk is 1.16, meaning that there is a 16% incremental benefit, the eradication rate, when you co-administer probiotic. And the subgroup analysis shown that the eradication was not different when you compare adults and children and between the Asia and the Europe group, and found that the Lactobacillus casei was better compared to Reuteri and GG group. Coming to hepatic encephalopathy, again the evidence is not that robust. 21 trials involving 1,400 patients. Compared to placebo or no intervention, probiotic probably improved recovery and may lead to improvements in development of overt hepatic encephalopathy, quality of life, and plasma ammonia concentration, but no effect on mortality. Coming to inflammatory bowel disease, at least we have one indication, pouchitis. In mild active pouchitis, this is a study of 23 patients involving mild pouchitis treated with VSL3, which is a composite probiotic, 2 sachets twice daily for 4 weeks. They assess the efficacy by the pouchitis disease activity index and the quality of life using IBD questionnaire. Those who achieved remission, they gave the dose of VSL3, 1 sachet BD for 6 months. 69% achieved remission with this treatment, and there is a significant improvement in the quality of life. And all 16 who went into remission maintained remission during the maintenance treatment. Coming to IBS, again the evidence is not that robust. 23 trials involving 2,500 children and adults. It improved global symptoms. The predominant symptom improvement was in terms of improvement in pain and bloating. And they used a combination of Lactobacillus plantarum and E. coli. And there is one more study which showed that improvement in overall symptoms in terms of IBS severity score. Now these are the few of the studies mentioned here, single and the composite probiotics in the dose and the level of evidence and the improvement in terms of IBS symptoms. Coming to NAFLD, we are all aware that dysbiosis, leaky gut, and endotoxin release has been linked to NAFLD's progression. And studies have shown that in those who were obese and those in NASH children, there is increase in bacteroids and reduction in firmicutes. Similarly, in those with advanced fibrosis, there is a decrease in firmicutes and increase in proteobacteria. So these are the studies, the composite probiotics in the dose, and there is an improvement in aminotransferases, the HOMA-IR index, and the reduction in fibrosis in terms of elastography. Coming to prebiotics, what we discussed now is probiotics. Prebiotics, those I have only mentioned those studies which have got good evidence. One is lactulose in hepatic encephalopathy and functional constipation. The other one is oligofructose. Coming to lactulose in hepatic encephalopathy, 38 RCTs involving 1,800 participants. Lactulose is associated with beneficial effects on mortality. The relative risk is 0.58. There is a 40% improvement, less risk of death in those who were given lactulose. It also reduces the incidence of serious adverse events in terms of liver failure, hepatorenal syndrome, or variceal bleeding. It's a 50%, close to 50% risk reduction in risk. Functional constipation, again, lactulose and oligofructose have been found to be beneficial in the said dose. So to conclude, probiotic has a role in the management of infectious diarrhea in children treatment and the prevention of antibiotic-associated diarrhea. It may have a role in improving eradication rates of H. pylori and in the treatment of mild active pouchitis, maintain remission and prevent recurrence, improves the global symptom score in IBS, and prebiotics, lactulose has a definite role in the treatment and the prevention of hepatic encephalopathy and in the treatment of functional constipation. Thank you very much.
Following the viewpoint, we have a counter viewpoint. No discussion after that, no?
Yes, sir.
Yeah. Babu Vinish, to say that all this is a gimmick, yeah?
Okay, before I start my talk, first of all, I would like to congratulate Dr. Pirma and Dr. Arul on becoming officer bearers of the ISG. And the same go, I would thank them for inviting me to talk about probiotics or gimmicks. So, actually, so good evening from SIMS, and to what I know is to my teachers. So, before starting the topic, I would like to make a small cutie story. So, actually, Pirma called me a fortnight back. So, Babu, why not you talk about this topic? My first response was, sir, can you give it as a pro to me? So, and then I told Pirma that give me a day and I will come back to you. And after that, I went for a cup of coffee with my friend Dr. Gautam and our postgraduate Dr. Parag, and we were just talking about the topic. And while having the tea, I decided I should not talk about this topic of probiotics. And then the next dilemma came as what to do. It is pre, pro, and postbiotic. This topic looks too long to be talking within 25 minutes. So what I decided is I'll stick on to probiotics because pre and post are all dependent on the probiotic component. And then came the next dilemma. So how am I going to counter Dr. Gokul? So I know Gokul from my undergraduate days, a soft guy with a strong subject. So what can I do? Can I beat him in this? Okay, so I had two choices. One gives studies, the other is to give some facts about probiotics and let the learned audience take the decision. I know we all have a better abstract thinking than that of the general audience. So I think we should be able to rule in my favor. So, and then now going to the topic per se. So I'm going to talk only about probiotics. So if you see probiotics, if you just go to the WHO site and see probiotics in how many diseases they have used it in around 700 diseases. Do you believe a single microorganism can cure 700 diseases? Like the previous years, they used to say an apple a day keeps a doctor away. But now, as Gokul is trying to tell is, give one microorganism and you can remove all the 700 diseases present in the world. Is it even possible? Think over. Okay, and probiotics, So, and the spectrum of probiotics, it starts by Dr. Rama's study. In this study, what he did was, he gave probiotics to third trimester mothers to make a healthy microbiome in the unborn infant. So, what was the result of the study? I do not know per se, but he will tell you. But how did sir decide what is the healthy microbiome? I do not know. And you can see, when you see in the studies, you can see from this part, and it will go up to the part where you can delay aging. So probiotics delay aging. Do you believe that? So I think probiotics will help to stop the telomerase. I don't know. So Gokul will maybe counteract with that also. Okay. So going on to the topic. So how am I going to go on? So I am going to talk a few words about enteric mycobacteria, probiotic divisions. Why? See, Gokul has put in so many studies. So why you should not believe any of these studies? And what are the things you have to see on a probiotic cover? And do we see that? Adverse effects of probiotics. And since Gokul has put some slides, I have to show you some slides because we are all evidence-based medicines. And a single guideline only. So first of all, I would like to think the enteric mycobacteria. See, the number of microorganisms in our body exceeds the number of cells we have in our body. So what you have to do is, this microbiome, they have a relationship. A holobiont is there. It is not to be disturbed. This holobiont has a good commensal relationship with the host. So they have a good friendship. And when an infection or an inflammation occurs, what happens is they talk to each other. The host and microbiome talk to each other and try to solve the problem. Actually, we know that they talk to each other. Do we know how exactly they talk to each other? We have no idea. So you do not know what is happening in a normal individual. Without knowing what happens in a normal individual, how come you are going to give another bacteria and tell that everything is going to be all right? So it is absurd to the core. So you should understand this enteric this common talk. So next, going to the enteric mycobacteria. Is it uniform throughout the world? The answer is no. So this may be, I cannot get a better slide than this one. The most common microorganism present in India in the enteric mycobacteria is Provetella species. And studies we take is from US and Canada. In US, it is Propionibacterium. In Canada, it is Lactobacillus. And it varies between country to country. So how come a study done in US which has a different microbiota composition will be applicable to India? Does a single strain or genus has been screened throughout the world? The answer is no. What is the only thing which can change the enteric microbiota? It is only diet. So the diet is the thing which maintains the microbiota. See, we have extensively used rifaximin throughout the world as a luminal antibiotic. Does rifaximin change the luminal antibiotic, the enteric microbiota? The answer is no. And how come you expect giving a probiotic of lactobacillus to change the microbiota and help the patient? It is not at all possible. Is it possible? I don't know. So now you have to see the Indian microbiome. So the Indian microbiome, see, in Tamil Nadu, the most common microorganism is Provetella. We and Keralites more or less have a diet more or less equal. But there, the most common organism here is Bifidobacterium. The studies in Tamil Nadu has been done by Balamurugan, Kabir Das, Ramdas, all are who are PGs, postgraduates, and the corresponding author of all these studies is Dr. Ramakrishna. So Dr. Ramakrishna should tell that probiotics are of no use only. So probiotics, how come they are so famous? Why did Dr. Pirama and Dr. Arul ask me to talk about probiotics? See, there is a review by Kajal in MedRev. He took 300 randomized control trials over the past 20 years and stated none of these papers, that is 300 RCTs. So you can calculate the number of trials there. And he told, it showed probiotics had no determinantal effect on the health of the human health. So what is the thing which is provoking everybody to write a probiotic? As Gokul told, it is the market. It is an $85 billion market. So everybody is pushing. The pharma is pushing. Everybody is pushing. You see the growth there, 8.1%. In India, it is 21%. It is more than the growth expected in our country. So from where this comes, you know. You have literature here. I can even lay down my talk here with this one slide itself. But I will go on. So this is the International Scientific Association of Probiotics and Prebiotics. So this is probably a society which supports probiotics. They have divided probiotics into 4. Live or active cultures is something like curd, in which we think it has live cultures but has not been proven. And this should not be taken to imply probiotic activity. It is not who I am telling, it is the association who is telling. And probiotics in food or supplements without a health claim. In Western countries, supplements are added with probiotics. Here they told it is better to avoid it. The third is in which a food or a supplement is being supported by a health claim. So the probiotics which we use on a day-to-day basis. In these probiotics, characterization of the strain of the probiotic is important. And the strain should prove that it has a health benefit to the individual. And it should be in a target population. So there, as I started the slide, there is no probiotic which has been proved efficacious all over the world. And how come we can write probiotics? The fellows who support probiotics itself tells few probiotics only have met their requirements. And probiotic drug, where a probiotic is given as a drug, we know it is not given as a drug. So next, see, we are doctors, we like to prescribe. Okay, so in order to prescribe a drug, probiotics have to be accepted as a drug or a biological agent by any regulatory authority like DGCA, USD, FDA, something. Are probiotics accepted as drugs by anybody? The answer is no. So nobody in the world, no regulatory authority has approved probiotics as drugs. It is a supplement which is masquerading as a drug. So we should be thinking twice before writing a probiotic. So are you going to give a probiotic to cure a patient? Are we doctors or are we quacks? The answer is with you. No authority has told. So if you are going to give it for treatment, be my guest. So next is, don't rely on studies. As my Gokul is smiling, he has a lot of things to tell. So I have given all references in the end of the slides. Anyway, it is going to come onto YouTube after some time. You can use the reference to see whether I am right or wrong. Most studies have potential bias. What is potential bias? There is something wrong in the study, in blinding, in randomization, in analyzing, something is wrong. So for an example, of 46 studies of probiotics in IBD, only 23 were double-blinded. In these 23 studies, they used 32 types of probiotics. See, the number of studies is 23, but the number of probiotics is 32. And in those studies, 10 had different probiotics and 4 used symbiotics. And most studies use qualitative data. What is qualitative data? In an IBS patient, sir, I think because you gave this tablet, my gaseousness has decreased. This is qualitative data. Are you going to use the qualitative data to use for a probiotic? I don't think so. Or these studies use markers which do not have a necessary clinical significance. For an example is insignificant reduction of CRP in a healthy individual. And trials are generally heterogeneous and lack sufficient power. So heterogeneous, you cannot approve a study in a child using that of an adult. And also they have a restricted enrollment criteria. For an example, in a highly hyped study of using lactobacillus to prevent antibiotic-associated diarrhea, they enrolled 135 patients, but the study arm was only 8%. And they told that lactobacillus prevents antibiotic-associated diarrhea. And the other thing is, when you give a probiotic, you also give some other drugs. You do not know, there is always a confounding factor of another drug. So how come you can give probiotics alone? No. Next. So in any study, no study tells the number of, the content, the viability of the probiotic. Is it standardized? No, it is not standardized. If I think this is 10 power 10, it is 10 power 10. And Cochrane reviews our data sets, all the Cochrane reviews are is based on small and variable results of studies. So basically even a Cochrane review cannot be believed in while studying probiotics. So now I have told you why you should not give a probiotic using an enteric mycobacteria example, why you should not believe studies. Now we will go up to the important thing of probiotic labeling and their significance. See, before you write a probiotic, you have to see whether what strain it is. Has it been tested in an RCT in a heterogeneous population? The dose and viability should be given on the probiotic. And is it equal? See, the number of, I'll explain the dose to you in the subsequent slides. And a whole gene strain characterization is important. So this is a cramped slide. I couldn't get a better slide. This is what the Europeans tell, what you have to look in a probiotic before prescribing a probiotic. You have to see the ingredient. Whether it is a capsule tablet. What is the genus? What is the strain? What is the species of the probiotic? What is the colony forming unit in this probiotic? How many times you have to give the probiotic? What are the advantages of giving this probiotic? Can you show me one Indian probiotic with this amount of information? No, there is none available. So what are, this is, I just already Gokul discussed it. So my point here is all bacteria of a genus or a species have a probiotic component, but that is specific only to a strain and not to every species in that genus. Okay, now comes the thing. The next slide is what are the few commercially available brands. I have put up a few commercially. How many in this audience, we as gastroenterologists are the persons who prescribe most amount of probiotics. How many of us know what is the composition of an of a probiotic? You might know lactobacillus. So what is the species? What is the strain? What is the colony forming unit? What temperature it has to be stored? It is most common, see, the most thing we have studied in Schlesinger is the D-Simon preparation, that is VSL3 preparation. How many of us will know how much CFU is there in Bifidobacterium in VSL3? I bet it will be less than 1. 1 is itself is a higher thing. So there is no way we are prescribing VSL3. You know what is the dose of rifaximin. You know what is the dose of amoxicillin. When you are in bed, if somebody hits you and asks you what is the dose of amoxicillin, you are going to tell. But if you are fully awake and have the book in front of you itself, you ask the dose of a probiotic, nobody will know. So that itself tells these probiotics are gimmicks only. We study the drugs, so we remember the drugs. So they are game changers. These fellows are only gimmicks. So here, if you see here, this is a cramped slide because I cannot make it into multiple slides here. I want you to see 2 to 3 things here in this slide. See the storage. Storage is 2 to 8 degrees. 2 to 8 in VSL3. And in the other things in which the pharma guys comes and tells us that it can be stored at room temperature, the room temperature is 30 degrees. See here, any probiotic, 30 degrees, step out of this hotel, your temperature is 40 degrees. And how come you can give this and expect a cure? There is no way you are going to expect a cure. And in all these preparations, none of these preparations other than the D-Simon preparation has a colony count more than 10 to the power of 10. And this 10 to the power of 10 is including the whole thing, even in the D-Simon complex. It is not a single microorganism. And now you have to see the content of the content. See this content, you see here. Here, the first is Saccharomyces cerevisiae. They give 2 billion CFU. 2 billion CFU. And you come down. Here, it is given 250 milligram. So, 250 milligram is equal to how much CFU? I don't know. Then you will have to come back again. Again, I want to say you. These are things you have to note. 2 billion spore of polyantibiotic resistant bacillus. It is not one. Multiple antibiotics. Okay. So, that is where we are. I am going to see these things I am emphasizing because the subsequent slides you will know the consequence of these things. So what are the concerns about the marketed probiotics? They are taxonomically incorrect. And I would like to see any of this, have they mentioned the strain? Everybody has mentioned as lactobacillus, the gene, none have mentioned the strain. They have mentioned the genus, and species, and not the strain, except for Lactobacillus rhamnosus GG. So, only one probiotic in India has mentioned the strain. I am perplexed to see. And what did we see in this previous slide? Only a particular strain can be useful. So, I don't know. So, change in the species or strain can alter the results. So, this is just 2 examples. So, there was a study by Lactobacillus with the Lactobacillus porogens, an RCT including 70 individuals both in the treatment arm and control arm. And what did they find? Watery diarrhea, Lactobacillus porogens had no use. Then comes the GG study. This is called the lead study, in which the study population was 1900. Don't get skewed by the 1900. And they told supplement improves the during diarrhea. But in this study, I wanted to tell you, in this study, the species itself, there is so much variation in the study. In this lead study, 1900 individuals, of which 1300 received rhamnosus GG and 200 were lost to follow up, and the other 400 or odd received control. and they concluded that supplementation improves diarrhea. I don't know how. So next comes the colony forming units. I told you, you have to see for colony forming units. This is a meta-analysis. See, this meta-analysis and all, I can just put your diagram here. So here what I want to say is, see, when you see it, this is less than 10 to the power of 8 microorganisms. So less than 10 to the power of microorganisms, the probiotics have no effect at all. No effect. And how many of our commercially available probiotics have more than 10 to the power of 10? 0. So then 10 to the power of 9 or 10 might or might not. More than 10 to the power of 10, it might help in preventing diarrhea. So you do not have a probiotic which is having an adequate dosage. You cannot store the probiotic. They do not know the strain of the probiotic, and you want to go and prescribe the probiotic. I don't know. Gokul, you are prescribing, I think he should be, he has a lot of guts. So the next thing is probiotics. Are they safe? The first question, doctor, what is wrong in giving a probiotic during giving an antibiotic? I am trying to save the enteric microbiota. First point we have to notice, we do not know what the antibiotic does to the enteric microbacteria. First point itself, we do not know. And we are adding a probiotic to help to recover the enteric microbiota. The first point itself, we do not know. How can you talk about the second point? So, and we do not know how probiotics alter the intestinal microbiota. Their effect of the mucosa and the lumen is limited. And one study by Swiss showed a delay in microbiota reconstitution after antibiotic exposure. So then comes the adverse effects of probiotics. So infections. So Lactobacillus bifidobacterium are the most commonly used and the most common to cause bacteremia. It is seen, bacteremia is seen in around 0.05 to 0.4%, in which Lactobacillus is more commonly involved, because Lactobacillus has a greater propensity to translocate. And this Lactobacillus rhamnosus GG has been associated with the increased risk of SMV thrombosis. Patient is dehydrated. In a diarrhea case, for an example, already the blood is clotted, and you are going to give one microorganism which has been proven to increase the rate of SMV thrombosis. The next infection, fungemia, which can be caused by Saccharomyces. These infections are more common in immunocompromised, recent surgery, or after antibiotic treatment. See, probiotic-induced infections are polyantibiotic resistant and difficult to treat. So, probiotic also alters the immune system. So, how does it immune? So, it may stimulate phagocytosis in a normal healthy person. But in persons with allergies, this effect is opposite. It affects cellular and humoral response. The immunomodulatory effect can also depend upon the dose of the probiotic. And we know that the bacterial cell wall has peptidoglycan, which can cause a serum, which can cause fever, arthritis like symptoms. So again, probiotics. What is the determinal metabolic effect on it? See, we know bacteria divide bile acids. So you are going to give bacteria, it is going to divide your bile acid, it is going to cause bile acid diarrhea. So what will happen to the bile acid which is there? The probiotics will again act on it, and it will convert it into secondary bile acids. This secondary bile acids is going to enter the enterohepatic circulation and increase the risk of colorectal carcinoma. And next is, humans produce L-lactic acid. Microorganisms produce D-lactic. So already there is a lot of microorganisms in the body, and it is already a damaged gut, and you are giving a probiotic and you are increasing lactic acidosis for a person who is simply itself prone to develop lactic acidosis. So probiotics also could cause an increased risk of intestinal mucus degeneration, thus causing inflammation and an increased bacterial translocation. So next is potential transfer of genes. So potential probiotics have a potential to transfer antibiotic resistance genes. Now only I told you they are giving bacillus in a polyantibiotic resistant form. This polyantibiotic resistant form will give by plasmids to the enteric microbiota. From the enteric microbiota, it is going to go into the circulation, and we are going to have multi-drug resistance for a probiotic, which we know doesn't cause any useful effect. So 68% of probiotic strains are resistant to 2 or more antibiotics. 70% of lactobacillus are resistant to vancomycin and a whole gamut of antibiotics. Bacillus, as I told you, even displays a high level of resistance by itself. So then now, even though I told trials are gimmicks, but I'll have to also tell because it is a scientific audience. So functional pain syndrome, a Cochrane review in 2023, little or no difference between probiotics or symbiotics. They were unable to draw a meaningful conclusion. Second, functional constipation. Systemic reviews suggest that there is a limited evidence to support the use of probiotics in functional constipation. This is from 2017. Next is irritable bowel syndrome, a meta-analysis using Rome 4 criteria. So that is just in the past. 6 RCTs, 9 probiotics, no significant reduction in IBS scores or improvement in quality of life. So then why do you give the probiotic? I don't know. So maybe it is useful in children. Children, it might reduce abdominal pain and gaseousness, but there is little evidence. And there is no use in constipation or GERD. So the British Dietetic Association reviewed again 9 systemic reviews, which contains 35 RCTs, and concluded specific probiotic recommendations for IBS were not possible at this time. Acute gastritis, I have just displayed 2 studies, one in Canada, one in US, both used lactobacillus to show that, and it showed it was of no use. Both were randomized controlled trials. And in a meta-analysis of RCTs in Lancet, 34 out of there were 35 studies, 34 were done in developed countries. How come in developed countries the enteric microbacteria is similar to a developing country? And in that country also, they told it might be beneficial. It is not sure. And in another study of over 4,000 children, the quality of evidence with this regard was very low to low, leading to omission of probiotics from the NICE guidelines. So if out of 12 guidelines, 7 guidelines do not recommend it. 5 guidelines gave a conditional recommendation. So we are in a democracy, so it is of no use. Next goes antibiotic associated diarrhea, the Plaza trial, which is the most important trial, and it didn't find any benefit in reducing antibiotic associated diarrhea or C. difficile. Another study with the Lactobacillus rotari also. Another study in India using Lactobacillus acidophilus and bifidobacterium for antibiotic associated diarrhea concluded the prophylactic administration did not lower the incidence of antibiotic associated diarrhea. So next going to Clostridium difficile diarrhea, a Cochrane review. So they told no use. Another meta-analysis showed Saccharomyces boulardii only in children, and that too of low evidence, and not in adults. So the number needed to treat antibiotic associated diarrhea. So if you see here, it is number needed to treat one diarrheal episode. To prevent one diarrheal episode is 25, 40, and I have just put a comparison to you for NSAIDs and pain. So the number needed to treat is 1.8. This is a drug. This is a supplement. So going to IBD, in ulcerative colitis, there were 7 RCTs, of which one was in India by Sood. Of all these RCTs, all were small. Of these small RCTs, 2 were large using VSL3, and one showed no difference, the other showed a weak evidence in remission. 5 RCTs to maintain remission using bifidobacterium appeared to have some effect with low quality of evidence. Everything is low quality, nothing is strong. And pouchitis. Gokul was telling it was helpful. But what is the study population? Totally 78. So with 78, they are going to tell a recommendation that it prevents pouchitis and maintains pouchitis. In Crohn's, for remission, maintenance of remission, post-surgery, in none of the above, probiotics are useful. So other diseases in which probiotics have not shown to be effective, pancreatitis. In pancreatitis, it causes excessive death due to intestinal ischemia, and the study was withdrawn. Microscopic colitis, traveler's diarrhea, diverticular disease, and then liver diseases. HE. In HE, the Cochrane review, as suggested by Gokul also, majority of the trials had a high risk of random error. That is, bias was there in the studies, and a low quality of evidence, and probiotics may lead to little or no difference in mortality. In preventing SBP by Pandey, Sarin's group, they told it is of no use. Post-liver transplantation symbiotics might help, and the number of people in both these studies were 30 people, just 30 people. So the last slide will be AGA guidelines. What does the AGA tell? So in treatment of C. difficile infection, IBS, IBD, probiotics only can be used in a clinical trial. In children with the infectious gastroenteritis, they are advising against the use of probiotics, and the quality of evidence, it is moderate. And in children and adults, to prevent CDI, pouchitis, they are giving a recommendation, but the recommendation is a very low quality evidence. So we do not have studies, we do not have a logic in prescribing probiotics at all. It is like in yesteryears, for preventing diarrhea, they initially prevented them to drink water, and it led to death of a lot of people. In acute gastroenteritis, in yesteryears, they prevented people from drinking water. And then evidence came that drinking water will prevent death, and then only they included it, because in the yesteryears they didn't have a good study to support their effect. As of now, there is no good study in probiotics, and do not prescribe probiotics. With this, I keep my stand. Thank you.
So I think as a debate rules go, Gokul has the opportunity to defend.
I forgot to ask one important question. How many of you have prescribed probiotics for your patients? Everyone, I agree. So we all depend on the good quality evidence before we had given all those prescriptions. So don't get disheartened. We have good evidence like what I already showed. Few of the points, let me discuss. What relevant points let me discuss. 700 diseases he told, but all these studies have been taken up because it has shown benefit in other studies. So more and more diseases get included for the study on probiotics. The healthy microbiome, as he told, is very difficult to estimate. So we can't tell, just because we are not able to identify those things, we can't tell that there is no benefit. Studies have shown the fecal microbiota composition has been analyzed in those who received probiotics, and I do agree that a lot of heterogeneity was there, and whatever positive things we got, there was definite change in the fecal microbiota composition in those studies. So a lot of difficulty in defining what is. Geographic variation accepted because studies what is done in US and Australia may not be fitting here. So we need our own guidelines. We need our own studies to find out whether it is useful. He told about the AGA guidelines not recommending probiotics. So we can't extrapolate to our patients. So we need data for our own patients. Strain-specific effect is already known. So the studies which I showed is the Clostridium, the Rhamnosus GG, all those are strain-specific studies which have been done. So I agree that it is very important. Strain-specific effects have been known, and the very important point is that this is not a drug. It is still a supplement. Therefore, standardization is not possible. So once this is made into a drug, we will have more standardization, more relevant studies. As of now, it is only a food supplement. I do agree with you. Regarding the dose, 5 billion studies, Cochrane database has shown that at least 5 billion colony-forming units is required for the beneficial effect. And most of the probiotics which are available in the market, I have seen it is mentioned. For example, I don't want to mention the brand. Those containing Rhamnosus GG, 6 billion colony-forming units has been mentioned. You told nothing is mentioned in VSL3. It is mentioned, 110 billion units. So we have to look into it. Because we are not bothered, we are not looking into it. Now, side effects is already known. We don't prescribe these probiotics for immunocompromised people. Those with short gut syndrome, we don't prescribe them. So we have data that we can't give those things to such patients, and we don't use them in such patients. So it's not relevant here. So barring few indications which I showed, which has got definite evidence, the level 1 and level 2 evidence, like for example in antibiotic-associated diarrhea, or infectious diarrhea in children, or in mild pouchitis and IBS, we don't have enough data for other indications. So we are not bothered about those indications. Is there any specific question you want to, because too many things you have told, it's very...
See, actually, Gokul made my job easy. When he presented, he told everything has only low evidence. That itself is a victory to me before even occupying the dais. Hey, it was your study, man. All the slides, little or low, little evidence.
Level of evidence. So whichever is good evidence, I have showed.
The others you
I
have.
was frank in putting the level of evidence and tell you which study you can take and which you should not.
Yeah, but I'm telling you, no study is fine.
More?
No study is fine.
Is good. Okay. I mean, we have evidence. We can't go by that way. We have a systematic review and meta-analysis of several trials.
That's what I told you. My first slide was, he reviewed 300 RCTs, not 1, 2. 300 RCTs and told it is of no use. We leave it. Thank you. Thank you. Actually, it was a good presentation by Gokul.
No, let the final verdict be the audience and the expert, not us. It should go by the scientific evidence. Okay.
So I think it is a very lively evening we had today. A very nice presentation by Gokul, and a very lively repartee woke us all up by Babu Vinesh. So I don't know that there are any clear winners in this. Both have outlined points that all of us need to take into account when we practice, and we have to be kind of cognizant of everything that both of them said.
So any comments from the audience?
So we'll call for a popular vote.
Yeah.
If I don't write, somebody will write. So I'll write. That's the only point.
I think we'll have the vote by floor now. So convinced by Gokul and say that there are at least 2 or 3 conditions with level 1 evidence, and a restricted prescription is, so we'll have 3 groups. Restricted prescription. So,
thank you.
So number 2, so because 300 RCTs have shown that it has not done any harm. So like when you go to temple, you always get some prasad like that. So like multivitamins, those of you who will, routinely, like ENT and orthopods, they write PPI as a part and parcel of their prescription. How many of you routinely, I know one person at the back who uses probiotics for all our IBD, no one who is looking at the phone, no. So one who recklessly, not recklessly, liberally use probiotics. Now, number 2. Second group, I'll own up to it. No, liberally. So, who really, and I don't think even Babu Vinish will raise his hand, but who really says that the probiotics is not a drug? I'm a pure prescriber only of legally, and by pharmacy, pharmacology degree, I will not prescribe a supplement because it does not come under legal purview of my report here. Who does not prescribe any probiotic?
Thank you once again.
Like, who mentioned democracy?
Sir has been highly skewed. What he told you have to recognize here. In 300 studies, they have not shown. What did I tell? It is not of much clinical influence at all. What did Dr. Basu tell? There are no side effects. So he is a probiotic man. So the judge is skewed. It is a trial. This is an error, potential error.
Our grandfather said, first do no harm. So except in acute pancreatitis, which our father said, father of probiotics, and immunocompromised, I think probiotics have not been shown to do any harm. That's why I said, like a placebo. No, I prescribe folic acid, some simple non-harming medicines, because people don't want to leave the clinic or consulting room without anything. So that's my pragmatic view. But the final word should come from who.
No. So just as an aside, I should say that when I joined SIMS and used to do ward rounds and see all the patients, all other units as well, my observation was that every patient had 2 prescriptions. One was PAN, the other was Bifilac, and those were written by default. So that's where they are. I actually tell all the guys, and Babu knows this as well because I say this every day, that I think probiotics are for healthy people. They're not for sick people.
It's time to say thanks. So thank you, Patron, ISG office bearers, and particularly Dr. Ubaldas for, as we are taking that baby steps, he's just helping us to organize this meeting. We had a wonderful academic session today, and from multiple case reports, healthy debate, and I think all of us should have learned well this evening. So I'd like to thank the pharma company, Forts, and audiovisual team and the sponsors, and we can join for dinner now. I think it's not too late. Probably we are 20 minutes behind the schedule. Next time probably we'll keep in time. Thank you.